Ma'am, can we wait until 1:35 to start the session?
No problem.
Dr. Simon, I think start the session, please.
Okay, ma'am. Good afternoon, everyone. I welcome you all back to the first day of Hisicon theme, Healthcare-Associated Infections, Addressing Challenges and Unfolding the Solutions. Connected at all online. Epidemiology identifies the distribution of diseases, factors underlying their source and cause, and methods for their control. That requires an understanding of how political, social, and scientific factors intersect to calibrate the disease risks, which makes epidemiology a unique science. Reinfection could not be won over without the proper knowledge of epidemiology about it. And so, to explain about epidemiology today, to us, we have two amazing microbiologists, Dr. Khanisha and Dr. Shashikant. Dr. Khanisha is currently the head of Enteric Division at Department of Microbiology at PTMH Chandigarh. He has worked as infection control officer and now provides advisory role in National Infection Control Committee. Dr. Shashi Gandhi is currently head of microbiology at Government Medical College. Both the chairpersons have various international honors and awards, along with having authored a lot of articles in different journals. Now, I request both the chairpersons to take the screen.
Please put speaker slide. Next slide. Next slide, speakers. Requesting chairpersons to please introduce the speaker. Ma'am, you are muted, please. And
Hello.
now you're audible, ma'am. Yes, ma'am.
Hello.
Yes, ma'am, you're audible. Please continue.
Good afternoon, everybody. I feel privileged to introduce our first speaker, Dr. Aarti Kapil. She is professor in the Department of Microbiology, All India Institute of Medical Sciences. Her achievements are innumerable. Dr. Ajita Mehta Orientation Award by Hospital Infection Society, awarded the International Ambassador by the Society for Healthcare Epidemiology of America. Dr. S.C. Agrawal Orientation Award by IAMM. She has published more than 300 journals in index and more than 10 chapters in the book. She is the chief of clinical bacteriology laboratory and co-chairs of the Hospital Infection Control Committee of at AIIMS, and is very actively involved in research related to HIAs and AMR. Now I humbly request Madam to kindly take over. Thank you.
Thank you. Please start the.
Yes, ma'am. Still, voice is not connected.
Not audible?
Yes, ma'am. Just you're putting the voice.
Good morning, everyone. First of all, I would like to thank the organizers for giving me the opportunity to be a part of this conference and the present session. It would have been really nice if I could have been there in front of you and we could interact much better. However, in the present circumstances, which is beyond our control, I think let's try to make the best of an online system of my talk. I've tried to make it very practical so that you are able to remain interested. So let's hope you are able to learn at the end of it how to handle, manage, and investigate outbreaks in your hospitals. Since this is the first session of the present parallel session of epidemiology and outbreaks, I would just like to give the context of the epidemiology of healthcare associated infections and its relation to the outbreaks. Now, let us first look at the term healthcare associated infections. You know, this term has changed a lot over the years. You all must have read the term nosocomial infections, which is a Greek word and comes from the infections or diseases associated or given by a healthcare or a hospital. So for making it a little more descriptive, the word was changed from nosocomial to hospital-acquired infections. However, subsequently, this hospital-acquired word also was not very acceptable to the hospitals, as it's very obvious. It gives the meaning of hospital-acquired. It changed into healthcare-associated infections. It had some legal implications too, but not just that. There are other factors which were responsible for changing the name to the healthcare associated infections. I'm telling you all this because it has some context to the epidemiology and the outbreaks. So let us see why healthcare associated and not only acquired is because there are certain diseases which are inherent to the disease treatment in a patient who is either in a hospital, in the outpatient, long-term care facilities, hospices, etc. And that is the reason for changing the terminology from hospital to healthcare. Then why associated? There are some diseases which you cannot control. Endogenous infections, for example, in an immunocompromised host, reactivations. So some are associated with the disease, and as our number of susceptible population is increasing, so is the number of healthcare associated infections. Also, these reflect the quality of care and the commitment to the patient safety, and therefore a lot of attention has been given to the prevention of these infections. If we look at the epidemiology of healthcare associated infections and you go by your standard principle of epidemiology, you see it is always an interplay of agent-host environment. Agent, the organisms, we can't do much, and we have learned from SARS COVID-2, SARS coronavirus 2, that how the agent dictates. And we know MDR, so the organisms have to survive in their own environment. So we can't change much. The host is there as such, compromised or in any form of disease. But it is the environment we should like to modify, we would want to modify, and we can modify. So how is this environment important? As I mentioned earlier also, there are certain endogenous infections which are healthcare associated versus the hospital acquired which comes through the hospital environment. And if we are able to understand, differentiate the two, then we can focus on these hospital acquired infections which are preventable. So our energies should channelize towards these preventable infections. A large chunk of these are device associated infections and also outbreaks or clusters. So as my lecture is outbreaks and clusters, I'll also tell you the definition of these terms. But let me just again put this in the right context. There was one systematic review and meta-analysis which talked about the preventable proportion of healthcare associated infection. So because as I said, it is important to focus your energies on the preventable infections. And in this meta-analysis, they found that almost 35 to 55% are preventable infections and mostly device associated. And the other important preventable infections are outbreaks. And so if we can prevent all these, almost 60-65% of the infections can be prevented in a healthcare setting. So that is a major chunk. So coming to the proper topic, let's see what are the terms used in epidemiology. So I'm just recapitulating these terminologies for some of our residents, younger colleagues, students who may be a part of this session. So what is an epidemic? Epidemic is an increase in the number of cases of a disease above the normally expected level in a population in an area. So, and when it becomes a pandemic, the geographical area becomes large, population becomes large, it involves almost many different countries. And then what is an outbreak? Outbreak is an extensive transmission within a setting or organization, or even one episode of a rare occurrence. How is cluster different from outbreak? So there is no standard definition of a cluster, but each hospital can have its own definition so as to keep data on these things. So usually cluster is 2 or more cases associated in the same location. So outbreak is usually where you have an extensive transmission, whereas outbreak is linked to each other in the same time, but may or may not have the evidence of a continuous transmission. Now it is important to remember that not all clusters are outbreaks, but all clusters should be investigated to rule out the outbreak. So as we said that these are preventable infections, we must prevent. So before prevention, we must have to find out is there an outbreak. So you have to establish an outbreak. To establish an outbreak, our specific objective is to identify a source, break the chain of transmission, and control the further spread. Mostly a clue is given if you see increase in the number of cases from a particular unit, or you see that from a specific invasive devices, there are large number of cases of similar types, or you have these typical healthcare associated microorganisms like Stenotrophomonas, Pseudomonas, MRSA. So that gives you a clue. Then what you have to do, very important, is you have to have a uniform case definition so that you know they are all similar. The methods used for the diagnosis, that means to reach the diagnosis or identification, should be same. Your case finding methods should be the same that you will find from the literature and your own data. Because it's very important to be aware of the pseudo-epidemics, and the microbiology laboratory knows how sometimes pseudoepidemics can occur. You can have a whole batch of blood culture bottle getting contaminated, bronchoscopes getting contaminated, some handling in the laboratory, sample collections being inappropriate, and these can lead to some pseudo-epidemics, and then your energy spent on the outbreak investigation goes waste because they are not coming from a specific source to all these patients. Now let's see what are the steps one should follow to investigate an outbreak. First of all, as I said, it is important to have a case definition. You are all familiar how during COVID, during other infections, influenza, swine flu, there were always case definitions given. So here you have to have your own case definition based upon whatever information you have, but you can keep expanding this definition as you get more information. I'll share with you an example which we experienced in our hospital that will give you some more idea. Then you review the records, microbiology reports, you review literature, then you line list all the cases just to look at the before infection, during this infection, search all data to look at some pattern. And based upon this data, you draw an epidemic curve. So I'll show you all these steps with one case study, which is our own experience also. While daily reporting blood cultures, we noticed an increase in Acinetobacter baumannii isolation during the month of April. So it was all patients of bacteremia or sepsis. So then we saw that 9 patients were positive at that time from a particular ward, oncology ward, which is 10 cubicles of 6 beds each. So we made a case definition at that time that we have an outbreak of A. baumannii from blood culture from the patients admitted to the oncology ward with blood culture positive A. baumannii was the case definition. Because then these will all be our cases. All the patients admitted to oncology ward, culture positive for A. baumannii became our cases. So I'll tell you why the number of cases is important. But let's first go to the epidemic curve. First of all, you must establish, is it an outbreak? So after all cases you listed, as I told you from your data, you construct an epidemic curve. So this epidemic curve shows that yes, there is an increase in the number of cases. There is a sudden increase. So it is an outbreak. So this is somewhere here that we noticed and then intervened, and you see a decrease. I'll share with you some of the epidemic curves just to give you an idea. Normally, if the shape of the curve is like this, it means there is a point source. So there is one point. So like we had a point source. If you get a curve like this, that means there is a continuous source. Something is continuously insulting or causing the insult to the patient. Then this is intermittent. From time to time, there is one small cluster, you can say. So there are clusters forming an outbreak where the source is intermittent. So that's why it is important to line list cases and construct a curve. Then the next step is to fit into our definition of, is it increase over the normal in the same time during the previous year or along the year. So if you see in this, the blue is the previous year and red is the present year. So you see, while we do have A. baumannii from the culture coming as a routine over the months, but it's more or less same. And this year we saw a sudden increase. So it was an outbreak. So what next to do? Based upon this data, we revise the case definition. So this is just to give you an example of how one can go on expanding the definition while making it more specific. So now this definition is patient in oncology ward having a Baumani, the outbreak strain, because by then we have the antibiogram isolated from blood culture between March to June of that year. So increase. So two more things added. This Baumani should be the same as we have from this increase in the cases, and it should be during March to June. Now, why I said cases are important, case definition and cases, because to understand the risk factors and what was different in cases and controls, so that finally you know what was there causing this infection. So you design a case control study within your same organization. So you select controls, means the same patients in the same area but negative for your not fulfilling your case definition. So, and about 1:4 ratio is considered as a good ratio to come to a conclusion. So we selected these controls from these 10 cubicles who were admitted during the same time. On further analysis of the risk factors, we found that all the cases occurred in 2 cubicles, cubicle 2 and 3, among the patients who were on central lines. In 2 and 3 cubicle, there were patients who were not on central lines. They did not have this culture positivity. So there was no other focus of infection. None of the controls of 2 and 3 without central line, as I told you, or in other 8 cubicles with or without central line were positive. So none of the controls were positive. So what we found also that the nursing staff attending to these two cubicles each in this area were the same. And they had a common medication tray for their respective 2 cubicles. So for 2 and 3, there was a common nursing staff. So what was our hypothesis based upon the information that we had was risk factor was admission to the cubicle 2 and 3 and with central line. So this was somehow a risk factor. And the hypothesis was there is some common source, like because it is bacteremia, IV solution, IV medication, or the hands of the healthcare workers. Now, based upon this hypothesis, you then start getting additional cultures. So again, I'll reiterate here. Here is the role for environmental culture. This is what you call as epidemiologically determined environmental sampling. So then we collected a lot of samples, and almost 30 to 40 samples were collected, surveillance cultures from the various possible sources based upon our hypothesis, including the hands of the healthcare workers working there. And finally, what we found was that we had 6 Acinetobacter baumannii positive. 2 were from the heparin saline bottles at 2 points on 2 times, and 3 were on patients on IV dressing site, 1 from the IV saline bottle airway site. They had a similar biotype and antibiogram as was our patient strain, and the molecular relatedness also showed the same source. And a molecular relatedness, you're going to have a full lecture, so I'll not touch here, but just to show you that this is how they were all related. The patient samples, the environmental sample, and these are unrelated sample, and the molecular marker. So what intervention was done? So first of all, what was the cause? The cause was during that year in April, and you know April has a lot of festivals. There is Ram Navami, there is Good Friday, there is Eid, there is Holi sometimes falling at the same time. So that is what happened. So the regular staff was on leave, the staff was constrained, somebody was working as a makeshift arrangement, and not intentionally but not aware of how this can cause harm. They were not very careful with the infection control practices. And the other was the use of a common heparin saline bottle which lay in there on their trolleys and with the needle, and they were going and coming back flushing all the patients on IV lines. So the control measures that were taken, first of all, education, stopping the common heparin saline bottles and use of single-use ampoules for each patient, reinforcement overall of infection control practices, and you have my word that from then onwards till now, we never had a outbreak due to such common use solutions in the area. And this we published also subsequently. Now let me take you to another case study, because this is how you get the context. I'm sure you all see these cases day to day in your day-to-day practice. In a neonatal ICU, 2 premature babies died of sepsis in 1 week. So this was a bit unusual. So our pediatrician raised an alarm. They said it is not normal. Specifically, both were Pseudomonas aeruginosa, again not normal. Sometimes very sick premature babies do die, but both of them having same organisms was a cause of concern. Antibiotic susceptibility profiles also were different from our earlier isolates, which were endemic, because Pseudomonas aeruginosa used to come a lot of time from the respiratory secretions and respiratory samples, especially patients on some kind of a respiratory therapy. And this was different because mostly in our NICU we have ciprofloxacin sensitive. So this was one marker which raised an alarm. And so as I said, this was earlier only with the respiratory support. Then again, subsequently 2 more culture positive cases were identified over the next week. On further analysis, we found that only the babies kept in humidifier incubators had sepsis. So this was one type of incubator which is called as humidifier incubator. They had sepsis. We had other incubators also. There the babies did not have sepsis. So as I said, none of them in the other humidifiers were positive due to outbreak strain. So our hypothesis was, or the case definition was, the child who is kept in this humidifier incubator, and hypothesis was that this incubator care was somehow associated with this infection. Again, as I said, we collected a lot of environmental cultures at this stage from different areas of incubator, fluids, moist surfaces, soap, solution. So based upon your hypothesis, you collect relevant sample and collect a lot of samples, because if you collect 20, 30, 40, then there is a chance of getting 2 or 3 positive related bacteria. So what we found was the water that was used for humidification in the incubators was culture positive for the same strain. Antibiogram similar. And this is the molecular typing which shows the relatedness of these outbreak strains. And these are some of the unrelated profiles from the other areas of the hospital. What intervention was done? So first, what was the cause? Some water always used to remain collected in these humidifiers even after cleaning. Probably that was the nidus. Immediately their use was discontinued, manufacturers were informed, service undertaken, and it was subsequently the staff was trained how to clean these humidifier incubators so that there is no stagnation of water. So you all here, I must tell you as infection preventionists, be careful. Any tubings that are used, any devices that are used in the hospitals where water is used, please be careful that during cleaning, ensure thorough drying also at the end of the process. So with this modified cleaning protocols, this outbreak was controlled. Therefore, these 2 examples give you some idea that how you are able to, if you are a little vigilant, if you monitor your positivities from the lab end or from the clinician's end, you can at early stage, you can identify a possible outbreak. And therefore, the steps of investigation of the outbreak are very important, so that you first establish whether it is an outbreak, you make your epidemic curve, you make your hypothesis. Based upon hypothesis, you'll try to look at the risk factors. nurse. So this was just two examples that I shared. I'll just give you some of the newer other experiences which are seen in a healthcare setting, causing outbreaks with devices. For example, exposure to duodenoscopes. There was an associated NDM positive CRE E. coli which caused an outbreak of infection in one hospital. So this one has to be on the lookout for. This is not just a hospital. Recently, CDC has released this in 2021 only, where they report a multi-site. So it is in different sites, different hospitals. Outbreak of Burkholderia cepacia bloodstream infections associated with contaminated pre-filled saline flush syringes. So something like our experience, ours was the common use. But here what has happened was, probably, although they were all separate saline flush syringes, but at the time of the filling itself, there is some contamination. So there was this common nurse assist society kind of a thing, who were supplying pre-filled syringes to all the hospitals. So all those who used that particular batch, the patient had a positive Burkholderia cepacia in the blood culture. So these are some of the things which make sure that you remain vigilant and always check your anything that is used in the fluids in the IV lines. You have to be very careful about the strict manufacturing policies, and if at all there is a suspicion, you must alert everyone who is using this so that you can stop the further spread of this infection. Another organism one has to be very careful about these days is Candida auris. So all over the world, there are reports of hospital-associated outbreaks. So please be careful. You make your lab enabled to identify Candida auris because they're very resistant. It's not easy to identify them very easily, but by the routine methods. So please be on the lookout and please be careful for such outbreaks. Another organism which is again very resistant is the Clostridium difficile infections, the diarrheas. Fortunately, in India, we don't have much reports, but we need to be careful. In the end, I'll just tell you this paper, Detection of Temporal Clusters of Healthcare-Associated Infections or Colonizations with Pseudomonas aeruginosa into Hospitals. This is a comparison of two software packages. So my purpose is not to tell you compare these softwares, but what I wanted to tell you is that in our experience, it is what we found was we were vigilant, or our clinicians were vigilant, but things become much more easier, rapid, and uniformly implementable if you can have a software system to track the number of cases. So this is just to tell you about that. I thought this was one of the latest paper where in two hospitals they could see that this one Pseudomonas is endemic in this hospital, but somehow due to the transfer it got there was some outbreak in another hospital, and there then it became endemic. Although with the outbreak it got controlled. So this is how you can understand the transmission or temporal clusters in 2-3 different hospitals or different units within your own hospital setting. So therefore, in the end, I would just like to say that with all this information, knowledge and understanding of outbreaks, finally our purpose is prevention strategy. We have to be vigilant and we have to have an integrated approach, and with the infection control nurse, the microbiology laboratory, the administrator, clinicians and hospital epidemiologists. All of us have to play a very important role in able to control these preventable healthcare associated infections and bring down the burden of HAIs to a large extent. This you will have another lecture also. Next is the role of infection preventionists. So I'll stop here and thank you all for your patient listening. I know it's very difficult to remain attentive in an online lecture. I hope I was able to give some information to you which was useful to you. And I'm sure there is a system by which you can put your questions on the chat box. And I'll surely try to answer at some stage whenever the organizers share that with me. Thank you very much.
Thank you, ma'am, for a very informative lecture. And you tried to tell us about the importance of vigilance and that the hospital-acquired outbreaks are very much preventable. And gram-negative bacteria usually you showed that they are associated with heparin solutions or pre-filled syringes or humidifiers. Same is the experience. I think we also have a similar experience. And you nicely showed up a software, I think, which is really going to be the game changer in investigations of the outbreaks. So without, so do next, I now invite next person, that is Dr. Nanda Kumar, who will be taking, can we have his biodata?
Yes.
Yeah, he's head division of research and patents community medicine. So he is an epidemiologist in the Bangalore, Ramaiah Medical College, Bangalore. And he has first rank at BRDR Medical College, Bangalore University, at a Pfizer Award. And as you know that he has total 47 publications. And he will be talking about role of a hospital endocrinologist, which is a much needed specialty. So I now invite Dr. Nanda Kumar to give his presentation.
Thank you, ma'am, for that kind introduction. And it's really an honor to be amidst such stalwarts, because when I saw the list of people who have been on this podium for the 3 days, it's really nice to share a little bit of what expertise and experience that we have. And understanding from Dr. Aarti Kapil ma'am, who has very lucidly given a narration of approach to an outbreak investigation, and with specific examples of like how things sort of unfold. It is like more like an investigation or a detective kind of a thing, where we look at things which might for the uninitiated look like, okay, this is the first step, this is the second step, and last they get an answer. But believe me, for people who are doing that, especially in hospitals, it certainly is a challenge, because the number of confounders which we come across while we are trying to sort of like pinpoint a particular cause to an effect, it's extremely difficult. And also, thanks to the recent advances, probably in the end, when we have some time, I'll spend a couple of minutes on that. The systems of predictive analytics rather than reactive reasoning. So this has made a sea of change, because when we the electronic surveillance system for infection control has been there for last 10-15 years. Like HMIS have embedded modules for infection control, and I'm sure the experts, especially the senior people, would agree that like they were not helping to a large extent in the earlier avatars that they were there. So the sea of change that has happened in recent times is the omics that has been coming into the whole ecosystem of treatment and healthcare management, and also these smart or intelligent systems in terms of like the artificial intelligence, machine learning algorithms, and simple logic related integrated systems. So there is a lab information system which is connected to patient care system, and the numbers can talk for themselves. So with this, probably from where ma'am has stopped, I will try to just take the narrative to the hospital epidemiologist as an individual and hospital epidemiology as a department, and how they can contribute in the fight or war or against these healthcare associated infections. I'll share my screen. Yes, it's there. So is the screen visible?
Yes.
Yes.
Yes. Okay. So my understanding as an epidemiologist, we look at the whole thing in entirety. So I've been the co-supervisor for one of the PhD students. She recently completed her thesis on healthcare associated infections and a costing model for it. And also in the recent last 2 years during the COVID pandemic, I was part of the Karnataka state government core surveillance unit, where we literally had to bring in some of the principles of epidemiology beyond the realms of institution to infection control in large groups, like the cluster transmissions that were happening. Like we had a real-time monitoring of the cases, and the spot map using technology was done at the BBMP war zone, where we were able to say that, see, in the next 4 or 5 days, there will be more number of cases in these areas based on the SRFIDs and their locations. So such insights were there, and we were also able to sort of like do some predictive analytics for that. And as Dr. Aarti ma'am has told, like as an epidemiologist, we are always called for this outbreak investigations, as and when the number of cases, or if there is a sort of like deaths in post-surgical or VAP associated, any kind of hospital acquired or healthcare associated infections, we are part of that investigation. So just to reiterate, when it came to epidemiology, we have the triad and other things, but even in healthcare associated infections, the components of epidemiology in terms of distribution, more importantly, the determinants, are extremely important. In the sense, when we are talking of the distribution, the time, periodicity, is it related to a shift where some things are happening and the outcomes are different? Is it during a season because of the use of air conditioners, the HEPA filters not being cleaned, during that period is something happening? Or is it a trend once in 2 years where we have a fresh batch of nursing students coming in for something where the rates of infections are changing? So the periodicity or the time becomes extremely important. The place in terms of specific locations, as very evidently put across, let's say like Ward A versus Ward B. And there was a curious case where we were seeing that on the right side of a particular room, any instrument or any this thing we changed, still it was infected because there was a mold on the top because the roof was leaky and that had some fungal nidus over there. So in that sense, the location, regional distributions, all given same, but what is the difference? So like when we formulate an etiological hypothesis in the investigation outbreak, we look at similarities, differences, concomitant variations, and analogy. So these are the 4 ways in which we see that. And also the host attributes in terms of the age, gender, ethnicity, and so many other factors, like be it the immune competence or the immunocompromised states in which an individual is. The reason why we are focusing so much about this and a national conference exclusively for this is it does comes with a huge cost, where prevention is cheaper than management. So even in the previous slide, Dr. Sarala's thesis, when we looked at it, the average increase in the length of hospital stay for a patient with hospital or a healthcare associated infection was considerably and statistically higher as compared to someone without it. And from the logic point of view, if you realize that these are the patients who have come for treatment and not to get a disease. So in that context, makes logical sense to have this approach of an epidemiological approach in preventing and averting an event which can be sort of tackled. Coming to the Indian scenario, why do we think that we are different? Because like it's not just the numbers, it's not just because the Western models of infection prevention and infection control sometimes don't work for and in India. The reason being our healthcare system, which has a huge Pareto in terms of the government hospitals, predominantly India is still rural, and some of the district hospitals or the tehsils, when we go and inspect for various quality assurance parameters, even the basic things will be lacking, and there will be a lot of scope for improvement. So one is large numbers in a hospital. When we say that like this should be the minimal interbed distance, or in an ICU this should be the standards. We have the IPHS standards, the NABH standards, but meeting those standards at all places at all times is a challenge. The OPD caseloads aims, I mean, it's just not possible for us to have everything as per the rule book, and despite that we are trying to intervene. So in that context, there is a difference, and something which works in place A might not be the right suit for place B. The third is, we are not talking just about the patients who are admitted, but also the attendants and visitors to these places, where on an average we'll be having at least 2 or 3 people who come in as if it's okay, it's nice, and if you don't go and talk to the patient when they are admitted, kya sochenge wo log. So in that context, it is for every 100 bedded hospitals, you can easily assume that there are 300 people who are constant coming in and going out, which also adds to the confounding what I just spoke about. And also in terms of the environmental standards, be it the water standards, air quality standards, and the infrastructural requirements for ensuring hygienic and safety is a little bit questionable. I'm not saying that it's in every places, because the Kayakalp assessments, when we went to the government hospitals, the cleanliness and hygiene were far higher than some of the private nursing homes and smaller clinics that we visited. The other thing probably during the course of yesterday, I mean like today and tomorrow you would be hearing, is the indiscriminate use of antibiotics leading to resistance and infections through such resistant organisms, which can also cause some problems. And also the post-procedural monitoring and surveillance is not something which is standardized. Each hospital, each unit sometimes have their own protocols in terms of management and procedural, post-procedural evaluations. As a consequence, getting the denominator and identifying the cases before they occur pose a challenge. And of course, I'm not going to talk about the epidemiological triad. We have the agents, host, and the environment, and all these three put together sort of leads to what we are seeing. And what else has happened in the recent past, where the focus has been sort of shifted, is the patient-centric care, where we are saying that like the all factors goes towards ensuring a favorable outcome and the optimized outcome for the patient. So in the process, like it is not just the patient care, but it is the patient comfort that is coming in, and air conditioning has become a necessity. Something which was sort of a luxury has become a necessity over here. And the number of people involved in the care complex, be it the nursing, physiotherapy, dietitians, nutritionists, the patient interactions with the healthcare personnel has also increased. And whenever we want to identify who is the one whom we need to probe further for a particular outbreak, it becomes extremely challenging. So the complexity of the patient care has also changed, thereby increasing more and more layers of difficulties in sort of like intervening and standardizing the processes for preventing healthcare associated infections. Quickly, I'll just spend 2 minutes on this, for the reason that many people associate epidemiology with field epidemiology. When we say epidemiology, father of epidemiology, John Snow, there was a cholera outbreak and the spot maps resolved it. But what we need to understand is the Cynics study in 80s proved very effectively that if at all, if there is a surveillance, if there is a continuous monitoring of ongoing events in a given environment, we will be able to control, prevent, avert, and reduce these infection rates. That was a paradigm where the entire approach towards healthcare associated infections or hospital acquired infections was what introduced. So coming to the training, because some of the students might be listening and part of this conference, who can become a hospital epidemiologist, if at all, if there is a title, hospital epidemiologist. Personally, I believe each one who is working in a hospital should have an epidemiological thinking for them to ensure that the workplace is safe, not just for the patient, as well as for the individual. Because recent COVID has exposed that the risk for healthcare personnel is considerably higher or significantly higher as compared to the patients themselves. So in that context, unless the entire focus on the approach towards patient care, every individual should be trained at least with the minimal basic understanding of this, how the environmental determinants can have a role in these healthcare associated infections. But traditionally, if you look at it today, thanks to the introduction of some of the allied health courses like the MHA, the MPH, and all the master's level programs, they converge, bringing in specialities from multiple streams like nursing, dental, lab, or allied sciences, physiotherapy, into this realm of epidemiology. So public health courses, infectious disease master's program have at different levels, starting from a bachelor program to master's program, and you have MD, community medicine, and specific PhD programs, as you saw with the previous one of our students. There are specific programs at all levels for all disciplines to get trained in hospital epidemiology or healthcare epidemiology aspects. So the activities are far more important, or the roles these individuals are required, or what are the roles that they play is, first and foremost, is developing the standard operating procedures at institutions. Because we often see that a place which is NABH accredited or any kind of a quality assurance program is running will function differently than without any SOPs. So development of that SOPs in a meaningful manner will be the first and foremost role. Educate the health personnel with regards to do's and don'ts, training, capacity building will be the second component. Track infectious trends. This is where the predictive part, what I'm talking about, the hospital infection committee meetings, which mandate studying those trends, hospital antibiotic policies, what are the drug resistance patterns that are emerging is one of the function. The monitoring of the outbreaks and investigating them, as Madam has mentioned, will be one of the core functions to get the denominator. There are standard templates wherein we can collect it as per the CDC template, Indian Association of Hospital Infection Control Committee templates. So multiple templates are available where if you list and get that information, either using a software or through simple Excel analysis, we will be able to identify the risk scoring, the relative risk for each of the component, and pinpoint what is causing. So that is one of the things. Data management plans are extremely important, because most of the times we find that what is required for the denominator is what is missing. We might have 10 cases. 10 cases from how many patients? So that denominator tracking is extremely important for us to get the residual risk scores for comparing. And support quality assurance program, because every quality assurance program today has an infection control as a major and key component. So that becomes very important in ABH, and encouraging accreditation activities. So just to give an example, like when we interact with our colleagues at Johns Hopkins, the entire division is set up exclusively for this task and activity. And what they do is exactly what the roles what I have told in terms of comprehensive surveillance, investigation of cluster outbreaks, occupational health and safety trainings, and it's the entire gamut of what the infection control practices need to be in monitoring in a safe and sound ecosystem for entire health personnel, patients, and also the attendants and people who come in. So in this context, I'll stop here. In this context, hospital epidemiology is a science and an art. The science part coming in with the knowledge idea and also the ability to understand these risks. So the agent, host, and environment, it would be there, but how do you sort of like put them together? How do you create an ecosystem to collect, interpret, analyze, report such information which could be useful not only for systems improvement, but also for preventing and averting these infections? So I'll stop here and probably subsequently take some questions with the permission of the chair.
Thank you, sir, for being with us and sharing such informative session and emphasizing the need of this specialty. An epidemiologist and microbiologist are the two sides of a coin during an outbreak. Prevention is cheaper than management. Early identification can control the outbreak. So it's a joint effort of clinician, epidemiologist, and microbiologist. Sir, very well, you have very well explained the role of hospital epidemiologist for controlling the hospital-acquired infection, outbreak, and management. Thank you so much, sir.
Now we invite the third speaker, Dr. Vikas Manchanda. And Vikas is a professor microbiology and infection control officer, Maulana Azad Medical College and Associated Hospital, New Delhi. He is in charge of the COVID lab in MAMC, in charge of state lab for National Hepatitis Control Program Delhi, member project review committee ICMR, chairman technical committee NABH, member institutional ethics committee of MAMC, IIT Delhi, and he has over 80 publications and few book chapters and WHO monograms. Vikas will be talking on molecular epidemiology in outbreak setting. So Vikas, can we have you?
Yeah, this record.
Discuss in this particular session is molecular epidemiology in an outbreak setting. We all know that outbreaks are bound to happen in any healthcare setting, no matter how much precaution we take. The key is to early identify an outbreak and establish that particular outbreak and minimize the damage which has occurred. And further, it takes to that the prevention of the frequent outbreaks. So with this background, let us start with the presentation where we will be discussing or recapitulating the steps of outbreak investigation, then source, reservoir, and methods, then the epidemiological linkages, molecular typing methods, and molecular epidemiology of common pathogens which are incriminated as healthcare associated infections like Acinetobacter baumannii, carbapenem resistant Enterobacteriaceae, MRSA, vancomycin resistant Enterococci, and group A Streptococcus. And finally, a take-home message which we are going to have. Let us start with a case. A neonate diagnosed with bloodstream infection with carbapenem resistant Klebsiella pneumoniae in an inborn NICU on day 12 of life. That means the child has been delivered and is admitted to the same hospital ICU and is there in the ICU from last 12 days. There is no previous carbapenem resistant Klebsiella pneumoniae isolated from this neonatal ICU. Hence, no carbapenem resistant Enterobacteriaceae targeted measures were in place as a routine part of the preventive measures. So as soon as the information was given to the infection control team, immediate measures were taken in sync with the neonatal ICU administration, and there was immediate closure of the neonatal ICU for new admissions. The index case isolated to separate, physically separate area within the same ICU. There was enhanced environmental cleaning practices as per specified protocol and enhanced barrier nursing for all the babies who were there in the neonatal ICU. Then sampling was initiated for carbapenem resistant enterobacteriaceae screening, which included the rectal swab sampling for all the babies who are admitted in the NICU, rectal swab from the parents of the index case, and the environmental samples very focused to high touch services like incubators, armchairs, monitored ventilators, infusion pumps, sinks and toilets, along with the shared equipment like glucometer and weighing scale. So preliminary analysis, when the results were available after 8 hours, it was found that the 5 additional neonates are having the carbapenem resistance enterobacteriaceae as asymptomatic carrier. The molecular analysis which was done, which revealed that the index case was having carbapenem resistant Klebsiella pneumoniae, which was having OXA48 like and NDM1 carbapenemases. Rep PCR was conducted, which established that the mother and the baby have a same clone with 98% homology, that means 98% similarity. 3 other neonates, which were asymptomatic, have a single clone with 99% homology. Different neonates had the OXA48 like producing Enterobacter cloacae, and one of them had the Escherichia coli with NDM production. Environmental samples also grew the carbapenem resistant E. coli from the monitors and the adjacent sink, and all the environmental sample were found to have the single clone. So this gives you a picture that the complex environment in which so-called outbreak or the bug spread occurs. So it is not only related to particular antimicrobial resistance pattern, it is across the species. So cross-species transmission can occur. There can be asymptomatic carriers leading to the spread of infection, and it is sometimes become too late by the time the flag is raised that there is an outbreak suspected into the particular healthcare setting. So follow-up was done and all patients were managed as per clinical requirement. As they were discharged successfully, deep cleaning protocol was performed after last patient was discharged and the new admissions were initiated. All new admissions initially were screened for CRE at periodic intervals, and when there were no new cases in 1 month, the routine screening was discontinued. So this shows that the only phenotypic detection or the culture isolation is not good enough. You need to go to the molecular level to establish an outbreak and identify the various clones. This is the slide which is showing you the steps of investigation outbreak. We are not going into the detail. This is just to remind you that there are certain steps of investigations which need to be followed in a particular order. And in these steps, these molecular typing becomes the integral step when we are saying that, yes, you need to have the single clone, or you have the epidemiological linkages which are being established by the molecular typing. So what we need to know if we want to investigate an outbreak, or we want to prevent an outbreak, or we want to get ready for the outbreak, is to develop a matrix of reservoirs, source, methods, and areas for common pathogens which are suspected to be evolved or can be isolated in a particular patient care unit. Example here given is the Acinetobacter species, which is very common in India. in various ICU settings. So for Acinetobacter, for example, the common reservoirs include the wound, genital and urinary tract, perirectal area, and the skin, which is within the patient. Then there are the potential sources, instruments, burns, trauma, surgery, respiratory equipment, gloves, and so on. So you need to identify the pathogens. You need to list the common reservoirs and sources. And more importantly, you also need to write about, in case of an outbreak, how you are going to detect them, whether you are going to detect only from the patient or you are going to have the patient and environment combination of various samples and how they will be taken upon. And then finally, the comments or special things which you would like to do for that particular bug in case suspected surge of cases with that particular bug. So this particular slide shows the epidemiological triad, which is classically said that to study any epidemiology, you have to understand the agent, host, and environment. But in today's world, there is one more element which has been added to establish the epidemiological linkage, which is typing. So the triangle has become now the diamond for epidemiological linkages. So before we move forward, let us try to understand what we exactly mean by molecular epidemiology, because there are various techniques which can establish the strain clonality or the similarity, starting from basic antibiotic susceptibility pattern to serotyping and to biotyping, which are all the phenotypic methods. So they have low discrimination index. We will see what is discrimination index in the subsequent slide, which is leading to the need for the molecular typing. Now, this molecular typing is nothing but use of molecular or genetic markers to trace the development of infection in a population and to understand the transmission and distribution and evolution of pathogens. All three things, we can use this genetic markers or the molecular markers, which comes under the ambit of molecular epidemiology. There is a gray zone between the molecular epidemiology and the genetic epidemiology. Molecular epidemiology is all about the known genes. So you are evaluating the association of variations in the known genes with the risk of transmission or increase or evolution of antimicrobial resistance or increased virulence. Whereas genetic epidemiology typically identify the unknown genes which can influence the risk of infection. There are many molecular typing methods which are available, but there are few common ones which are commonly used, which can be broadly categorized into 4 different types. One is amplification based method, second is fragment based method, third is sequence based method, and fourth is genomics based method. Amplification methods use the specific set of defined primers for the amplification of specific known genes and then identification of the number or the extent of expression of those genes. So you have the random amplification of polymorphic DNA or RAPD, arbitrarily primed PCR or AP-PCR, rep-PCR, which is nothing but the repetitive element palindromic PCR, and VNTR typing, variable number tandem repeat typing, which can be used. They are very popular techniques, easy to perform. No major equipments are required for any routine molecular laboratory. It's all about the consumables. So can be done with the routine molecular equipments. Then you have the fragment-based methods, which is the pulse field gel electrophoresis and ribotyping. Here, pulse field gel electrophoresis is the one which is more commonly used. Ribotyping was initially used for typing of certain set of bacteria, but because of its own limitation, because of the 16S rRNA gene variability in number, lead to limitation of this particular technique, and it is more of labor intensive. So PFG typing is the one which is used more commonly among the fragment based methods. Among the sequence based method, we have the single locus sequence typing, exemplified by M typing for group A streptococcus and SPA typing for Staph aureus. and multi-locus sequence typing, which is again the very common tool which is being used for Salmonella and Staph aureus, and it is a foodborne illness network is also there, where MLST types are being monitored across the globe. Then, of course, we have now the whole genome sequencing available and is the gold standard as a evolving technique for molecular typing. So the basic principle we have discussed. Then there are certain pros and cons for all the molecular fingerprinting techniques. So no technique is best for all the pathogens which we want to study. So you have to have a matrix where particular pathogen can be, or set of pathogens can be typed using particular set of molecular typing technique. Before you choose a molecular typing technique, there are 6 different variables which need to be kept in mind. One is typability. That means it should be able to give the expected meaningful result to the method. For example, when we used to do the serotyping, there were many strains which were labeled as non-typable. That means you can't differentiate between those strains. So that means that typability of serotyping is relatively poor to the molecular typing. So typability is the one parameter. Second is reproducibility. No matter you do it n number of times or in different laboratories, it should give the same result. Third is discriminatory part. That means ability to differentiate unrelated strains. It should not be able to cluster the unrelated strain into large cluster of the strains. So that will reduce the discriminatory part. So this is one of the very, very key feature when we are selecting the any particular molecular typing method, and the index which is under which this discriminatory par is being monitored is known as discriminatory index. Then, of course, ease of performance. It should be easy to incorporate into the routine laboratory setup with the trained manpower. Then it should be easy to interpret with degree of lot of objectivity, rather than if 2 different interpreters are doing the results, they are giving different, and that should not be happening, or it should be very, very minimal. Then is, of course, the cost, very, very important aspect, the initial cost and as well as the recurring cost of doing the test. So these techniques have been deployed for the commonly used pathogens, where PFG is being deployed for almost all common pathogens which are there, starting from ESBL, CRE, Acinetobacter baumannii, and so on. Rep-PCR is being very frequently used in ESBL producing strains, but it is relatively lesser than PFG and MLST. MLST has also been one of the common typing technique which has been used, and whole genome sequencing is the one which is very, very commonly used now, especially for the carbapenem-resistant Enterobacteriaceae members and vancomycin-resistant resistant Enterococcus. So when you do the typing, you get the banding pattern on the electrophoresis. It can be either analyzed visually, which is very, very cumbersome and very difficult, and you need to have an expert in that. So you need to deploy certain statistical tools, which we are going to discuss more about in them tomorrow in our lecture on statistical tools for the healthcare associated infections. Here, just I'm going to tell you there are softwares which are available which can automatically detect the bands and generate what is known as dendrogram. So this dendrogram tells us the relatedness about the different strains, and it can depend on the discrimination which is being resolution of the typing technique in terms of ability to differentiate the strains depends on the number of bands. Too many bands are also not very useful as the lesser number of bands. Then this is just a giving you the example of RFLP, or the restriction fragment polymorphism, which is being used for Mycobacterium tuberculosis. where you can visually analyze and say that there you have a different strain or the same strain, but the extent of the similarity or difference can be done only after you develop the dendrogram. Then this is another typing technique which is used for mycobacteria, which is known as mycobacterial interspersed repetitive unit. It exploits the tandem repeats or the specific set of genes, their presence or absence in particular strains, and then you compare the two strains for the presence or absence of those genes, and it tells you whether they have the same, they are the same strain or different strain. So dendrogram is like a rooted or unrooted. There is a common ancestor, then it diverges, and then you have the branching, which branching is having a branch length. So branch length also tells you that if it is scaled dendrogram, it tells you to what extent it is distanced or different from the other person. Then you have the clade, which is there, and clade in which we have the differentiation which is seen around for which are being depending on the strain dissimilarity. So the dendrogram which is being generated through my molecular typing technique is very, very useful in understanding the results and relationship between the study strains. 16S rRNA sequencing is also being used as a typing tool in terms of relatedness, where we have V4 and V6 regions of the 16S rDNA which are being compared. V6 being more variable is very useful in having the understanding the discrimination or increases the discriminatory power of this particular technique. Then there are certain challenges with the whole genome sequencing, and major challenge as we have commonly perceived is the cost. So there was a study which was done in Germany where they incorporated WGS as a part of their routine real-time MDR monitoring surveillance tool in their whole hospital, and then they could conclude that it led to actually cost reduction of almost 0.2 million euro for that particular hospital when WGS was applied as a routine surveillance tool. So real-time microbial WGS was indeed feasible, produced precise actionable result, helped to monitor transmission rate that remained low after modification of isolation procedure, and ultimately saved money. However, there are certain challenges as we discussed in those 6 parameters. One is ease of interpretation. So you need local experts in bioinformatics to interpret the data. And more importantly, the data which is being output of the sequencing data, that has to be read in terms of clinical context. So that is very, very challenging and is now work in progress at many places all over the world. Now coming to the specific bugs, we have the molecular epidemiology of the Acinetobacter and Carbapenem resistant Enterobacteriaceae, which we can, which is one of the very, very common pathogen in Indian ICUs. So because of the dynamic nature of the genetic composition of Acinetobacter baumannii, because of its promiscuity to acquire drug resistance genes, the older tools, non-WGS tools, it is difficult to deploy and interpret. So molecular data obtained by PFG, REP-PCR, or even MLST not uncommonly demonstrate polyclonality, while transmission opportunity analysis clearly reveal that high probability of the horizontal transmission. So it is having too much of discriminatory power which is being coming up, so which is hindrance towards understanding the clonality. Low sensitivity of the surveillance programs for detection of asymptomatic carriers in gram-negative bugs or the reservoirs is another challenge for studying the molecular epidemiology. So these are the 5 tools which have been commonly deployed, which have been searched through the published literature: MLST, REP-PCR with PFG, SNP analysis, and WGS, where it has been seen through various comparative studies that whole genome sequencing is the gold standard. This is followed by the multi-locus sequence typing. This is followed by the REP-PCR and then PFG. So in case of an abrupt sudden outbreak in a unit with low background endemicity, PFG or Rep PCR can be deployed. Otherwise, in absence of WGS, MLST is the technique of choice, which is to be remembered for gram-negative MDROs. As far as MRSA is concerned, PFG, Rep PCR have been compared, and in a last study at Johns Hopkins Hospital, they found the agreement between the two techniques varying from 73% to 100%. Whereas in another study, what they have seen is that if the discriminatory index in the banding, because the discriminatory index depend on how many band difference you are going to treat it as a single clone. So if you reduce that threshold, then the clonality, there is a risk of putting two different strain into such same cluster. So they found that now this particular study found that PFG was better than Rep PCR. Then there is another important technique which is now coming up is the SPA typing for Staph aureus, and it is as good as the PFG, so does not require the special equipment of PFG. So again, routine molecular laboratories can perform SPA typing in absence of WGS as a typing tool for MRSA. As far as vancomycin resistant enterococci are concerned, there has been studies where the superiority or the comparison of various molecular typing technique has been done. It has been seen that PFG is superior to Rep PCR, and MLST is not that good when we compare it with the common molecular typing techniques which are available for VRE. WGS, of course, is a gold standard followed by PFG. So in absence of WGS, PFG or Rep PCR is the preferred technique. However, if you have MLST setup, it may be helpful for you when there are the evolving outbreaks over a long period of time. So there it has been found that it may be of help in doing the strain discrimination. Finally, about the group A streptococcus, M typing is the most popular technique which has been in use, and in study in Australia has found that M typing is superior to PFG when we are trying to do the molecular epidemiological studies for group A streptococcus. So M typing again can be done in routine laboratory setup with no special other equipment if you have the molecular setup available. There is another study from Switzerland which has done the comparison between MLST and M typing and found MLST as slightly superior, but of course WGS remains the gold standard for the molecular typing of group A streptococcus. So the lesson learned from today's lecture is there are complexities and challenges associated with investigation of MDRO spread. Outbreaks of MDROs are as good as gene outbreak because there is a lot of interspecies transmission which is happening. So you are focusing on one bug, but the source may be the other set of species which are there in the same environment where your host is there or the bacteria is residing in. Then traditional prevention and barrier precautions like gloves, gowns, cohorting, screening, their effectiveness in this context is still undetermined, but still it is better to use these prevention precautions because it's better to have than no precautions. Then all outbreaks are not certain. There are many evolving outbreaks. When you are studying the evolving outbreaks, the molecular epidemiology becomes more complex. Sudden increase in acquisition rate of certain MDROs in a given time and location on top of certain basal endemic rate is the evolving outbreak. So when you are studying the evolving outbreak, there is a lot of strain intermixing and polyclonality you will come across. So establishing the clonality or clustering is more challenging than a classical epidemiological outbreak where you have a lot of opportunities for patient-to-patient transmission establishment, which can be done relatively in an easier manner. So the important thing is the suspected cluster as soon as clinician find, they should immediately notify to the lab and lab should preserve the isolate for molecular typing. Further, routine or periodic typing of significant bugs is important aspect of surveillance program. It is like a sentinel surveillance for early detection of new strains. So this should help the laboratory not to standardize the things around when the outbreak is suspected, it is already in place. And when the outbreak is suspected, they can immediately do the clonal studies and establish or refute the outbreak. So mode of acquisition when you are studying, cross transmission is important part, patient, staff and environment and equipment. However, the emergence of the new resistance or the bug in the environment is also important and should be part of the surveillance program. While considering the screening of staff, you need to be more sensitive because the established decolonization protocol for staff are scarce. So how long you're going to juggle around with the movement of the staff in the different patient care units in the hospitals. And lastly, a way forward to the whole genome sequencing type of epidemiology for healthcare associated infection. There is need to determine the rate of genomic change in various organisms that cause healthcare associated infections, for which WGS is very important tool of health. The degree of genomic diversity that exists within and between hosts during infections and outbreaks is the need of an hour to identify them. An automated bioinformatics pipeline is required to allow the rapid and reliable data analysis and interpretation before it comes to many local laboratories for establishment of an outbreak. So with that, I would like to thank you all for your patient listening, and I'm open to the questions if the chair permits. Thank you.
Thank you, Vikas, for an excellent presentation, very lucid, and for bringing out all the differences between molecular epidemiology, the difference of genetic epidemiology, different tools which we can use, telling us about reproducibility, discriminatory power, and talking about the advantages and disadvantages of each technique. I'd just like to share a bit from our experience that pulse field electrophoresis used to be it's a gold standard, used to be a gold standard. Now the world has moved to VNTR typing that was used along with PFG. Then they moved to MLST. Now they have moved to whole genome sequencing, and we've rightly mentioned that now is the era of whole genome sequencing, and definitely as the cost is decreasing and the companies are becoming more expert in giving you data, what we need are good bioinformaticians and good pipelines and good softwares to analyze this data. So thank you for this very lucid lecture. Now I invite Dr. Shashi Gandhi to introduce the next speaker.
It's my pleasure. It's my pleasure to welcome our next speaker, Dr. Haris Mansoor Khan, Professor and Chairman, Department of Microbiology, JMCH AMU, Medical Superintendent of AMU. Presently, they are Department of Microbiology in Medical College and AMU Hospital. The major achievement of Sir is currently Principal Investigator of Viral Research and Diagnostic Lab, awarded the prestigious UC Chaturvedi Oration Award at the 50th Annual Conference of Indian Association of Medical Microbiologists, supervised several PhDs, MD thesis, project completed by Sir is evaluation of antibacterial properties of non-particle on isolate from skin infection, and various research publication in books, written the 13 chapters and more than 100 publication in national and international journals. We are welcoming you all, sir. Please come.
Chairpersons and participants, Good afternoon to everyone. Today's topic of my lecture is healthcare preparedness in future pandemics. When we were students, that time we thought that these pandemics are something in the history of medicine. All those outbreaks which occurred during that time and in the later part of the years were basically localized in different parts of the world. They lasted for a few months, and the mortality and morbidity were very few, and these were easily forgotten. But this particular pandemic which occurred with COVID-19 is something which I think we never thought that this will occur in our lifetime. The WHO also has said that the COVID-19 pandemic has shown that the world was not prepared for a pandemic. Therefore, if we fail to prepare now, we may fail again in future pandemics. The best time to prevent the next pandemic is now. In order to achieve that, we should have a sustainable preparedness for health, society, security, and resilience, and adopting a whole of society approach and breaking the panic then forget cycle. This we can see even in the first wave. After the first wave, majority of the world, they probably thought that this is over, and we tended to forget that there will always be a second wave, and that is where when the second wave hit us, there was a large amount of morbidity and mortality. Now, in order to do this, we have to have a need for transformative and proactive approach to prevent future pandemics, or even becoming more resilient against them. Pandemic management has been described as a process of anticipating, preventing, preparing for, detecting, responding, and controlling in order that the health and economic impacts are minimized. It describes all that needs to be done before, during, and after pandemic. It involves anticipating or predicting the occurrence of an outbreak such as that it could be prevented. If the outbreak cannot be totally prevented, they should be in preparedness so that there is a readiness to respond. Whenever there is an outbreak, immediately it cannot be prevented. It has to be first reduced and then controlled and then eradicated. So here our aim should be that we should be ready to respond to this particular outbreak. The early detection through a sensitive surveillance system is required where and when the outbreak occurs to limit its spread. This particular surveillance system again was something in a more or less dormant state in all over the world. That is why the response was very late. In fact, if the response was a bit couple of months earlier or 3 months earlier, maybe the outbreak could have been limited. The preparedness is a subset of pandemic management. Pandemic preparedness constitutes all the activities that have to be undertaken from the national to the health facility levels to be ready to respond effectively to disease outbreaks. An pandemic preparedness and response plan ensures that the routine surveillance system can detect outbreaks as soon as it occurs to ensure that the staff are organized to confirm, investigate, and respond. The pandemic and epidemic preparedness is to ensure buffer stock of drugs, essential equipment, materials, supplies are provided and maintained. And the last but not least is that we should have sufficient financial support for preparation and response to cope with the epidemic preparedness. The responsibilities and roles in preparedness and response, first and foremost, all over the world is the national government. The national government of any part of the world is responsible for the communication and overall coordination effort. It has to put in place the necessary legislation. So many legislation has to be passed in order to control any pandemic. Then the policies have to be made and resources have to be provided for pandemic preparedness. The capacity development, wherever there is less capacity, it has to be enhanced. And the response which is anticipated has to be taken care of across all sectors. The health sector, in which basically all of us are involved in, involves the providing of critical epidemiological, clinical, and virological information, and it should inform measures to reduce spread of the pandemic virus and its attendant morbidity and mortality. Now, non-health sectors are those sectors which are basically supporting the healthcare sector. In this, we have to have essential operations services during a pandemic to mitigate the health, economic, and social impacts. In here, we can also include the, say, for example, the municipal corporations, which does help the healthcare sector in trying to reduce the outbreak, in controlling the outbreak. Civil society organizations, we have seen in the last 1.5 years, some of the NGOs have been very proactive, and they have raised awareness, they have communicated accurate information, they have countered rumors, provided needed services, and liaised with the government during an emergency. All the efforts which have to be provided during a pandemic cannot be provided by the government. It needs help of the whole of society, and especially of good organizations, civil organizations, the non-government organizations, the NGOs. They all combine together to help or to coordinate and then try to reduce this particular pandemic. Families and individuals also have a great role to play in reducing the spread of pandemic. Now, if you see this influenza viruses, the COVID-19 virus, all of these viruses, we have seen that if people are adhering to the norms like covering of coughs and sneezes, hand washing, and the voluntary isolation of persons with respiratory illness, they contribute a lot to limit the spread of the disease. In this, we have also seen that apart from this measures, there are many families, individuals, as well as NGOs. They worked overtime and they try to help the needy people, those who are not having sufficient resources, by providing them food and medicines to their homes. Now, recommended actions before, during, and after a pandemic. Now, these have been recommended actions have been recommended by the WHO, by the different government organizations all over the world, and by the national authorities. They have been organized into the 5 basic components of preparedness and response. First one is the planning and coordination. Second one is the situation monitoring and assessment. Third, reducing the spread of disease. Fourth, continuity of healthcare provision. Fifth is the communication. In the first part, the planning and coordination, the government at the highest level has to first plan and coordinate what we are supposed to be planning for and which disease we are targeting first. So once we have got that in place, then we plan the different steps to control the disease. In order to do that, we have to have coordination among the central government, the state government, and up to the district level. So all of the different levels, they have to be a perfect coordination in order to achieve the aim of controlling the pandemic. The situation monitoring and assessment has to be a continuous process. It can be on a daily basis, it can be on a weekly basis, it can be through an IT sector. In that, we can see what is the situation now. After every week, we can assess whether we are able to controlling it, if there are some shortcomings, how we can overcome those shortcomings, and then assess the overall situation. By doing this, we can see how much this has helped in reducing the spread of disease. The continuity of healthcare provision is must. That healthcare provision should be continuously be taken care of. In fact, it should be upgraded as and when required. Communications had a great role in playing in controlling any pandemic. Now, this particular pandemic has really shown that the communications between different sections of the society, different sectors of the government, played a great role in limiting the disease spread of COVID-19. The hospital, naturally, as it always should be in the forefront. So hospitals should always be in a state of preparedness to participate fully, efficiently, and effectively to control the epidemic. We should have an emergency management committee, and this is something which has been recommended by all the different government agencies. So that should include the administration of the hospital, the medical and nursing care, emergency department services, infection control and prevention, security, engineering and maintenance, human resources, laundry, food services, cleaning and waste management, and communication. In the emergency management committee, it should be chaired by either the hospital executive, whoever is chairing the hospital, or by the principal or by the medical superintendent. So any of these three can be chairing the hospital emergency committee. Then we should be having a hospital emergency coordination center, a dedicated room, a dedicated hall, fitted with all the IT facilities, and we should be able to coordinate with different sections of the hospital and different sections of the government. Then we should have emergency risk management. For this, we should prepare a SOP, ensuring the hospital's epidemic preparedness. We should have continuously update on this situation by meeting with the respected areas wherever there is a threat of pandemic. The development and maintenance of hospital emergency risk management program. Now, this needs to be updated all the time, depending on the needs. Then the formation of an incident command group, development of an all-hazard hospital emergency response plan that includes an epidemic sub-plan specifying specific measures needed to cope with the epidemic. Now, depending on the type of epidemic we are dealing with, we have to have different measures for different types of epidemic. The incident group, command group has to develop an incident action plan. The infection prevention and control basic requirements are the establishment of a core infection and control program with clearly defined scope, functions and responsibilities, and adequate budget allocation for following elements. Now, the qualified, dedicated technical infection prevention and control staff should be aware of their respective responsibilities and functions and trained in the application of infection control and prevention measures. Now, in all hospitals in all over the world, they have an infection control program which has an infection control committee. They meet together. They have different policies for different sections. Now, sometimes these need to be updated. They have to be reactivated to take control of any type of pandemic. There should be technical guidelines, adapted to local circumstances for the management of infection-related risk. Now, this is important that it has to be adapted to the local circumstances. We cannot have follow a policy may be being followed elsewhere in the world, which may not be suitable to us. So we can always make minor changes to that without compromising on the quality of the guidelines. The infection prevention and control policies for routine measures and for the additional measures needed to address potential threats. So we always have infection prevention and control policy for routine measures all the time. But whenever there is something new coming up, for that we have to have additional policy. And early warning epidemic surveillance system linked operationally to the public health surveillance system is a must. Now, this was really needed, and this was somewhat wanting in the early part of this particular epidemic. But now the whole world, and especially in India, we have got a very good epidemic surveillance system, and which gives good feedback to the government. A system for continuous monitoring of the implementation of infection prevention and control measures is a must. For this, again, we should have probably a weekly meeting, or depending if it is more serious, we can have daily meeting. With this, committee should have access to a microbiology laboratory using standardized diagnostic and biosafety measures. We should have clean water and facilities for ventilation, hand hygiene, and isolation of inpatients, and for storage of sterile supplies. A system for ensuring interoperability with other hospital activities and units, such as waste management, laboratory services, pharmacy, occupational health, and so on. The waste management is a very crucial part in the management of pandemic. If the waste management is not good, then we can be providing healthcare hazards to the society as a whole, and to the staff and the patients and the attendants who come to this particular hospital. Then we should be having a regular training and participation in exercises in order to enhance their ability to fulfill their roles in implementing the hospital's emergency response. We should have a clearly defined infection control precautions for triage, flow, and placement of patients, and early reporting and treatment. This is a very crucial part in pandemic management, especially we saw this in COVID-19 when the bigger hospitals had to cope up with the trauma patients also, the normal medical emergencies, as well as the infected patients. So it was very crucial that the triaging should be done fast, rapidly, so that there is no unnecessary intermingling with different categories of patients, and as a result of which we may be getting responsible for transmitting the disease to, say, for example, a trauma patient. To establish environmental and engineering controls such as effective environmental ventilation and cleaning. So this is a part of the maintenance unit of the hospital. They take care of all these environmental and engineering controls. Then we should identify the minimum supplies and infrastructures needed to implement the infection control and prevention measures. Now this becomes crucial because every hospital or every healthcare setup may not be having unlimited amount of funds or unlimited amount of supplies or infrastructure. So we have to identify which is the bare minimum, which is a must. And over and above that, whatever we can provide is now in the logistic goals should be to provide the right resources at the right time, in the right quantities, and in the right places, in order to satisfy the increased demand and simultaneously not compromising the normal functioning of the hospital. To support management of hospital operations and the need for personnel, supplies, and equipment and transportation. Now, this is extremely important to how to go about to see how much we require of what things. We cannot afford to have less quantity of supplies. At the same time, we cannot have too much of supplies where we have a problem in storing those supplies, or even in where you may have the expiry of these supplies. So there again, we will have problems. So in logistics, we should have such activities as procurement, transport, and stock monitoring, tracking, and reporting. This is very important that all the time we should keep an eye on how much things we have procured and what is the stock position daily. This position of essential items like PPEs, like N95, like normal salines, like so many other things, we should be at the tip of the finger every day morning. So if there is a shortage of some staff, then we have to become proactive in trying to get this particular amount of equipment or whatever things are required. The logistic required is for anticipatory proactive management approach. Like I told you that whenever there is shortage of some items, then the problems start because usually during a pandemic, all the essential items become short in supply. It's difficult to obtain the supply, and we need the supply in a very short time. So we have to be we should be very alert to this, and the management which is responsible for procuring this should be very proactive. Then assess the current hospital's current logistics system and likely priority needs for resources and supplies during emergency, including equipment and means of transportation. The hospital pharmacy is very crucial. This is more crucial because most of the medicines have got a shelf life. Now, these shelf life depends upon different medicines. Now, these we have to be very careful that the amount of medicines which we are getting in the hospital and which we are storing in the hospital should not get expired. But at the same time, we should not fall short of it. So stockpiles of special supplies and equipment such as antimicrobial, antiviral medicines, and personal protective equipment, adequate management of healthcare necessities such as blood, oxygen, solutions, vaccines, laboratory reagents, and disinfectants. This time we have seen that in the second wave, we have seen what is the problem of a shortage of oxygen. Now, because of the proactive policies of the government, now throughout the whole of India, all healthcare facilities are being provided with sufficient amount of oxygen facility by setting up of oxygen generator sets. And in many of the hospitals, they have got liquid oxygen. So we have got multi-tier systems in different hospitals to take care of any oxygen shortage in the if there is a third pandemic. The preparation of policies and procedures that are used for managing routine, non-emergency pharmaceutical services has to be prepared, has to be all the time updated, and if there is any changes to be made, it should be made, and the people who are responsible for it should be made well aware of. The laboratory goals, we should have laboratories which should support the hospital's preparedness and response activities, and that too in a timely, efficient manner. To contribute to the healthcare surge capacity by providing laboratory services needed outside the hospital also. So we should be, the bigger hospitals should be in the place to help the people who are outside the hospital also. The laboratory, by prioritizing the laboratory's activities, should strike a balance between the needs and positive agents of an epidemic and to ensure continuity of routine testing services. So it is not necessary that we should only be taking care of the epidemic, only the patients who are affected by it. We are also looking, we have to be ready to look after the medical emergencies, of the trauma cases, and for the obs and gynae patients are always coming all the time. The guidelines consistent with local policies and laws are issued by WHO or by the national government on collecting and transporting specimens taken for purposes of infection control and prevention. This is extremely crucial that it should not be limited only to the laboratory personnel, but it should be this particular policies regarding collection of specimens should be informed to all the sections of the hospital staff, because many times the collection is not proper. As a result, the results of the lab test is not good. The preparing and updated inventory of laboratory equipment, reagents, and consumables. Now here again, the same, like we said in case of medicines, like what we are doing, the RT-PCR, it is a continuous battle to try to get the sufficient amount of agents and consumables in the right time with the limited resources available, and the suppliers who usually start falling short of supplies during the peak of any epidemic. Then we have to double check with the suppliers as to their ability to provide laboratory supplies or to get additional technical staff. So you should always identify the suppliers who are reliable, who usually not ditch you at the wrong time. The patient management is that it has to be managed, that a proper action plan is in place for hospital management, admission, and up to the discharge time. Now, this is extremely important that we should not overburden the hospital system. So the proper patients who need admission should be admitted, they should be properly treated and at the right time to discharge. Because we should not delay the discharge, because if we keep delaying discharge of different sections of the patients, then we are occupying the beds, as a result of which the fresh patients are not getting their admission. It is safe and effective, and in such a way as to be beneficial not only to patients, but also to hospital staff and the community served. Functional, sustainable triage criteria in line with the Ministry of Health recommendations for admitting and admitting patients and for organizing the triage process so as to avoid exposure of other hospitals, patients, visitors, and staff to risk of infection. This was a big headache or big difficult part which we faced during the present pandemic in the triage area. Large amount of patients coming, they were used to be mixed up, so it had to be hurriedly triaged and put in different areas so that minimum area time is required to segregating the different patients. Standardized measures such as vaccination, administration of appropriate medication, use of personal protective equipment for transmission of infection to hospital patients, staff, and visitors. Now, this is extremely important that even in this first wave and in the second wave, we found that a large amount of our own staff, including right from the senior consultants down to the MTS staff, they got affected by the particular virus, they or their near and dear ones, as a result of which we fell short of hospital staff. So it is very important that their health should be taken care of properly. Standardized protocols for the treatment of infected patients should be formed and kept changing as per the government guidelines as and when they come, so that we don't have same protocol all the time. Because if there is a change in the line of management, we also should change the line of management in the protocol. Develop procedures for the management of outpatient care in such a way so as to avoid exposure of uninfected patients to the risk of infection. For example, we the establishment of telemedicine cell for non-emergency OPD patients. So whenever we had a OPD closure, because when the pandemic was at its peak, there were large amount of patients coming, then we had to close the routine OPDs. Then we started the telemedicine cell. Each of the departments had their own mobile numbers, which was given to the press, which was circulated widely among the media, where they could consult the different departments consultants during a particular time, so to take care of their non-emergency problem. Action plans to be formulated. The concurrent emergency that the hospital is able to continue providing essential health services for another emergency at the same time as coping with an epidemic. Like I told you, most of the hospitals had to cope up with the normal emergencies like obstetrics emergencies, like pediatric emergency, medical emergency like myocardial infarction or a road traffic accident. So we had to take care of those patients also, apart from the normal pandemic patients. Psychological and social support services are extremely important. We have seen in this particular epidemic, even with the persons who are not affected, they were facing a lot of psychological problems. They were very scared. They were very apprehensive about their own health, about the health of their near and dear ones. So it is very important that there should be some people around, those who are expert in providing this services, to be able to help them. Thank you so much for this patient hearing. And I would like to get any feedback from any participant. Thank you so much.
Over the years, we have had many reports, review and recommendation, all saying the same thing. The world is not prepared for a pandemic. COVID-19 has laid bare the truth. When the time came, the world was still not ready, said by WHO Director General in his opening address. So thank you so much, sir, for your illuminating talk and highlighting how to gear up for any future pandemic, so we can prevent the future pandemic and protect our future and future of generation to come. Thank you so much, sir.
Now we invite the last speaker, Dr. Mohammad Salman Shah. Dr. Mohammad Salman Shah is Deputy Director of, and he's a Deputy Director in the Department of Community Medicine at AMU. And Salman, you have not written much about you, but I know that I work very closely with Fatima, his wife. So without any more delay, I would like to invite Salman for clearing doubts and resolving controversy. Professor Salman.
Thank you, ma'am. I thank the organizers, especially Dr. Fatma and Dr. Raman Sadana, for giving me an opportunity in this big platform to deliberate with the speakers who are specialized in their own arena, and to speak before the chairpersons, namely Professor Neelam Taneja. I would be taking the session forward with raising doubts, and further we will be resolving controversies with deliberation with the expert speakers. So the first topic was outbreak and clusters. And Professor Aarti Kapil has listed 10 steps of an outbreak investigations, whereas Professor Manchanda enlisted 13. So what I'm going to tell you is that depends on what reference or resource you use. The list may look a little bit different from one source to the next, but really, if you look closely at any list that describes these steps of an outbreak investigations, you will find pretty similar steps. Sometimes they are combined or expanded further, but for the sake of simplicity, there are listed 10 of them. It's important to realize that these are listed in sort of a conceptual order, but in reality, during an outbreak investigation, several steps may be happening at the same time or in a different order. Most notably, step number 9 being control measures. Oftentimes, at the beginning of an outbreak investigation, you may have some idea of what the cause is. If you have an idea about the source or the way the disease is being transmitted, you may want to go ahead and put some control measures in place even before you have tested your hypothesis or performed additional studies. So in a way, we are going to go through these stepwise approach, but in real life, in an outbreak investigations, these may be happening in less of an order, so as to speak. On the other hand, one thing is certain, that failure to use this stepwise approach to outbreak investigations may delay identifying an outbreak, waste resources, that is skipping steps leads to pursuing pseudo outbreaks, and delay in identifying the etiology of infections. Most healthcare associated infections occur sporadically and not as a part of an outbreak. Outbreak, however, can be severe, garner attention, and cause fear. Investigating outbreaks may add to the knowledge about the pathogenesis of emerging pathogens, plausible mechanism of infections, new statistical or novel epidemiological studies, new laboratory testing techniques, illustrate new infection control and other control measures, identify regional and national outbreaks, the need for newer surveillance system, and the need for newer guidelines and regulations. Now, among the issues and the control measures, after the initial step of an outbreak are performed, one may need additional studies to identify the source of an outbreak, as Professor Aarti had done a case control study. And the settings in which these additional efforts should be considered are when the resources are available, the outbreak is associated with severe disease or high mortality, newer or unusual pathogens or mode of transmissions, outbreak continues despite control measures. Number 2 issue being the choice of best comparative study, and that depends on resources, time, and the size of the outbreak. The two most commonly used studies are case control studies and cohort studies. In the case control studies, we all know that patients are compared to controls who do not have the adverse outcome or infection, but would have the opportunity for exposure. And the advantage of case control study, that it can be used when outbreaks are large, when long period of exposure are present, and when many potential exposures need to be reviewed. But the disadvantages being that it only establishes that the case were more likely than controls to have been exposed to potential risk factors. In other words, it only calculates the odds ratio. Now the issue is about the best control group. What can be the best control group? Whether some cases and controls should be matched on some factors, how long the variable of interest should be collected in cases and controls, choosing which variables to be examined, only those clinically and biologically plausible due to the possibility of false positive association, in other words, type 1 error. In cohort study, the assessment is in a forward direction of time and evaluates what exposures are more common among those who develop the disease or infections versus those who do not. The advantages is relative risk is able to be calculated, and it shows an exposure is not just associated but denotes causation. Now, issue number 3 is once a study is conducted and analysis is planned, one area of controversy is how best to influence of confounding factors such as severity of illness and length of stay. One method is matching the controls to cases on these factors. The disadvantage being that once there is matching for a factor, that factor can no longer be evaluated. However, other methods after data collection in this regard could be stratified and multivariate analysis. Issue number 4, when to perform environmental cultures. For most part, environmental cultures should be guided by the fact of investigations, data from analysis, and biological plausibility. Non-directed cultures can waste resources and could yield positive results that would lead the investigation in a wrong direction. In a similar fashion, healthcare worker cultures should not routinely be performed and should be guided by epidemiology. A culture should be positive, could be positive, but not have any relationship to cases. Example, healthcare worker in a neonatal ICU may have cultures positive for MRSA, but does not necessarily mean that this is the cause of MRSA in NICU babies. Thus, positive cultures could adversely affect the healthcare worker, including unnecessary reassignment or removal from clinical duties and stigma. And issue number 5, when cluster appears to affect patient in a specific unit or population, example, patient undergoing specific surgery, there may be pressures from administrators to close that unit or stop that type of surgery. It is important that these decisions are driven by data, can be justified, and that specific criteria are set for when to close, but more important, what would need to happen to allow the area or procedure to open or resume. These were the doubts that were raised in the topic of outbreak and clusters. Now I'll take up the questions in continuity after the doubts have been raised with all the topics. Now the interesting issue of another interesting issue of hospital epidemiologists. The healthcare epidemiologist of the 21st century is typically an infectious disease physician with a specialized set of skills and competencies. Similar to their predecessor, Ignaz Semmelweis, today's epidemiologists identify outbreaks and intervene to prevent healthcare-associated infections. There was an interesting study from Johns Hopkins, to which Dr. Nanda Kumar was referring to, not with this study, but he was referring to Johns Hopkins. The results from the survey indicates that the role of hospital epidemiologists continues to grow, but many respondents do not believe there are enough resources and support to meet the increasing number of demands. Hospital epidemiologists have become essential for hospitals in terms of public reporting, improving quality of care, monitoring for antibiotic resistance, and preparedness for emerging and re-emerging diseases. In this survey, 200 hospitals that conducted research in healthcare epidemiology, 69 investigators from 202 institutions responded to the survey, most of whom were hospital epidemiologists. Most hospital epidemiologists reported no additional resource to support their growing responsibilities and complexities and challenges of infection prevention program. Active surveillance culturing for MRDOs was one of the most common duties. 90% performed active surveillance for MRSA, 59 for vancomycin resistance enterococci. In other words, mostly they were linked to infection prevention and control. Other responsibilities included monitoring environmental cleaning programs in 80% of the hospitals. Most hospitals, 85%, according to them, have antimicrobial stewardship program, and these programs are expected to increase further. That was the highlights of the survey with respect to hospital epidemiology. We'll come to specific questions and controversies and allay them. Now coming on to healthcare preparedness in future epidemic. Yes, certainly the world was not prepared for a pandemic. The situation of the developed and developing countries was alike. However, the response to combat was different. And there are myriad of causes and reasons. It was rightly said that we need to plan ahead, plan well in advance. And this was rightly said by Professor Harris. It reminds me of the famous proverb, it was not raining when Nu built an ark. So we need to plan ahead. If we don't do, the history may be repeated. There has to be measures directed as sustainable preparedness for healthcare securities and resilience. COVID-19 will not be the world's last health emergencies, and there is an urgent need for sustainable health emergencies preparedness to deal with the next one. Cycle of panic, then forget cycle has prevented the development of an effective emergency preparedness across the globe. The world needs to break the cycle once and for all. It was also rightly pointed out that there has to be a holistic approach involving everybody, all stakeholders, including community. The pandemic management should encompass the before, during, and very important, after periods. Even after pandemic is over, the world should rely on surveillance system, strengthen the existing IDSP, Integrated Disease Surveillance Project. The government has to think a lot on financial support, health budget has to increase. And delegation of responsibilities are very important at the national level among the health sectors and civil societies. Balance between need to identify positive agents of an epidemic and to ensure continuity of routine testing services is a challenge for laboratory services in a hospital. Continue to provide essential health services for another emergency at the same time as coping with an epidemic in concurrent emergencies is also one of the problems. There are certain potential pitfalls that needs to be kept in mind while preparing a preparedness plan, that the hospital can amplify an epidemic by various means. I won't go into details because patients who come up, then they are discharged, they transmit the infection to the community. Then there is overwhelming demand for healthcare. Pandemic may overwhelm a hospital's capacity to deliver healthcare services. Human and material resources, including hospital spaces and medicines, may not be adequate to meet the demand, particularly in case the pandemic lasts several weeks or months, and particularly if concurrent emergencies are underway in case of disaster. Overwhelming complexity. We all know hospitals are among the most complex institutions in the form of multidisciplinary team, highly diverse patients suffering from wide range of problems. And there is a limit time to forge or strengthen partnerships. So partnership, this has to be built in, maintained, and further new partnerships should be forged well in time. Now we come on to the various controversies or various questions. My first question to Professor Aarti Kapil is, ma'am, how does one make sure that the reported increase in number of cases is indeed an outbreak?
Yes. So thank you. First of all, I must thank you for clarifying all these doubts. You have very nicely put them all together, the key messages. So I think the doubt, so like it will start with a doubt first, and then you go on to establishing. And as you rightly said, we must start intervening, even if it subsequently doesn't turn out to be an outbreak. So as and when, so we'll establish only if we have a case. First is the increase in the number of cases based upon the experience, either in the lab or by the clinician.
And then you go on making a case definition, line listing, and draw an epidemic curve. But at the same time, in parallel, you also try and at least start educating the staff, try to implement stronger infection control practices and reiterate everything. So it all goes in parallel. In the end, it may or may not turn out to be an outbreak, but then you must start with all the possible suspicion of an outbreak and then go on to establish by case definitions and then looking at your data, literature from microbiology, from your clinical records. So in short, that is how would be your beginning.
Thank you, ma'am, for giving an insight into that pertinent issue. Now, before I move further to another speaker, one question to Professor Aarti Kapil is, what are the challenges in outbreak investigations?
So I think from the microbiologist point of view, first of all, of course, is establishing whether it is an outbreak. Then second thing is when you say it is an outbreak, you are to some extent also implicating the hospital in terms of its failure in being able to take care, which should have happened due to the ongoing surveillance, ongoing practices. So it should not occur. That is the first thing. So these are some of the challenges. This is one of the challenges ethically, sometimes legally, that you may face. And there comes the importance of making sure that your protocols are in place, your surveillance is going on, and therefore some of these not preventable or somehow due to circumstances beyond your control, some breach has occurred, but because of your vigilance, you should be able to demonstrate you've been able to take care. There would definitely be damages in times to come to be paid by the hospital for such breaches. I think briefly, because I'm aware of the time, so if that answers your...
Yeah, ma'am, thank you. You have given a very crisp answer to that very question. If time permits, I'll come back to you. The next question to the field of hospital epidemiology is to Dr. Nanda Kumar. Is what are the challenges abound the field of hospital epidemiology and in the role of hospital epidemiologist?
Thanks, Dr. Salman. Specifically, when it comes to challenges, there are systematic and systemic challenges. Like in an infrastructure, the availability of data. In fact, it goes back to your previous question of how to identify the outbreak. So when we say that, like from a statistical point of view, they will say that mean plus or minus twice the number of standard deviation is an outbreak. But when it comes to healthcare acquired infections, even one case of what that was not supposed to be there is an outbreak. So in that sense, continuous availability of monitoring data will be the first and foremost challenge. The second is a monitoring system with trained personnel to identify. Many times what happens is like it would be right in front of your eye, but it will be missed for having that knowledge of identifying it. Third challenge is the system for response of that in terms of like, I mean, there would be a problem or an issue of water or something which might be a contaminant, but getting to the root cause and immediately correcting it, which might sound a little bit out of place, but we have seen a problem not being solved and the cycle of infection continuing or recurring at a later stage. So these are the system challenges for not just epidemiologists, but the system of hospital epidemiology as such.
Thank you, Dr. Nanda Kumar. If time permits, again, we'll come back to you. Now, question to Professor Haris Manzoor Khan is, seeing the healthcare, the condition of healthcare system, can the existing healthcare system meet the challenges of future pandemics in terms of strength, weaknesses, and opportunities within the health system?
From my experience, what I've seen is the healthcare preparedness as far as the facilities goes. We have had an experience of how to deal with the pandemic. The biggest problem, and which we'll be facing later on, is the manpower. Because like I told before, that many of our senior consultants down to the MPS, they went down with this disease, as a result of which they could not come for their duties. Already they are overstretched, and above that, when there is manpower, could not come. So that becomes a real big problem, because of which we are not in a position to provide all the facilities which we can give in a normal situation.
Okay, sir. Okay, sir. Thank you. Thank you, sir. Now over to Professor Vikas Manchanda, an expert in the field of molecular epidemiology. Sir, what is the gold standard for validating markers of exposure and effect?
Yeah. Thank you, Dr. Shah. When we are talking of markers for exposure, that means first thing is that there has to be a clinical endpoint, that the disease has occurred. So the marker should tell us correctly that disease has occurred. And the second part of the validation of a marker is that if the intervention happens and that patient is treated, for example, then that marker should tell us now that the disease has disappeared, So it is like, one, the presence of the disease, and then the absence of the disease once it is being cleared off. So the typical marker is the one which is going to tell you both the things. One, the presence of disease, and another is the absence of disease.
Okay, thank you, sir, for explaining that very concept of molecular epidemiology. Over to, if chairs allow, I may take one issue with Dr. Nanda Kumar. Sir, there lot is being talked about digital epidemiological surveillance, various barriers to implementation. So my question is that what is digital epidemiological surveillance, and what are the various barriers to implementation, including legal, ethical, privacy barrier, organizational, and workflow barrier?
Thank you, sir. In fact, given the time, that itself would have been a session, I'm sure, for the esteemed team, where we could have looked at what are the information systems and informatics systems for addressing hospital data as such. But quickly, to just answer to your question, in fact, I started my session with this, saying that like 10 years back, the systems were reactive, where they were collecting information and they were giving us data for us to analyze and find out something. But in the last probably 3 or 4 years, thanks to intelligent systems in healthcare information systems, where we have embedded machine learning and AI-based analytics, which give a predictive modeling of data, both real-time dynamic analysis and OLAPs and online analysis of cloud-based databases can happen, with so much of interlinkages between the lab data, patient data, and in fact, from the billing, sometimes insights are derived saying that this for this package, 4 days the patient had to stay and they have stayed for 6 days, why this variation is happening. So in that sense, there have been huge advances in the technology. Coming to the second point you made about the challenges of that technology implementation comes in terms of the patient data safety, security, the various requirements, both in terms of hardware and software for maintaining these databases, and technical team who need to understand the implementation. And as doctors believe, we find that anything that is newly introduced, this is coming one more step in what we are going to do. So that kind of a resistance and hesitancy to adapt and adopt these systems might be a technology adaptation challenge, which might happen in the implementation part. And the third thing is the validity of the data on which these decisions are going to be made. Because the afferent streams or the input of data in most of the hospitals, even where we have an electronic health records, is not to the extent where that intuitiveness which a specialist will be able to find out the difference in the response or something. So that data integrity, data fidelity is missing within the system. So it would be what we would say as a learning in progress, and we need to have our conventional systems with trained manpower, with the data streams coming in with good quality. There would be some means of change in the coming years. Hope I have answered your question, sir.
Thank you, Dr. Nanda Kumar. Certainly, you have, in short, you have answered a very broad question, but you have touched upon every aspect of it. A quick response from Professor Aarti Kapil on what are the ethical issues in outbreak management and investigation, rather ethical issues in outbreak investigations and management.
So as I mentioned, ethical issues are also to some extent legal, both combined. So, but ethics-wise, the patient is entitled to know that the particular infection has occurred due to some breach. So I think for that, morally, ethically, the hospital must inform. But at the same time, conveying clearly that all appropriate and adequate steps are being taken to make sure that this stops, it is controlled. And I think at some stage, there would be legal aspects also, or reimbursement, financial issues. So that probably at some stage, India is not yet reached there because our people are not still that aware of their right in this sense. But I think in US and all, already insurance companies have started to tell that if the hospital is responsible, then reimbursement, the financial aspects has to be borne by the hospital itself. So I think these are some of the ethical as well as legal issues which we have to strive in a healthcare setting so that we achieve the best and make sure we have processes in place to avoid occurrence. So like Dr. Anand, so predictive rather than reactive. So we must be able to predict and take care much earlier. I think that is, to my mind, is the answer to that.
Thank you, ma'am. Thank you, ma'am. You highlighted that if there is an outbreak, if it occurs in a hospital, in a corner of the hospital, the patients and the family members should be informed about. Besides this, the prevention and the control measures should be in place as quickly as possible. I think we come to an end of this from my side. I thank all the panelists for allaying the controversies, answering to the controversies, and shedding light on very pertinent issues around the topic of epidemiology and outbreak. Thank you once again. Over to the chairpersons.
Thank you, Salman, for a wonderful synopsis, I would say, and bringing out the controversies. And as Dr. Aarti and you have rightly mentioned, that outbreak investigation steps, they go on simultaneously. And ma'am said, whether you get the outbreak at the end, you declare it or not, but at least there will be some advantage of investigating. And when we go to the area, then you can actually strengthen the already prevalent hospital infection control practices. We all are human beings, the thoda out of sight, out of mind situation ho jata hai. And rightly mentioned that I wanted to hear more from Dr. Nanda about the digital technology he's using, but maybe another time. And I think that's the way to go ahead to predict that what's going to happen rather than reacting to what is happening. And Dr. Harris wonderfully mentioned from his heart, he told about how he has managed actually managed the pandemic, COVID pandemic, and I really like that what he said, that triage is very important, and you have to get your stuff proactively before you have to anticipate that we might be needing that. And one very sticky question was when to close the unit. It is basically the administrators also who actually need to be convinced to close. Sometimes the microbiologist is saying this outbreak will not go till you close the unit. But there are so many pressures, administrative pressures, political pressures to keep the unit open. And I thank all the speakers and my co-chair and for this such a nice, highly informative and lucid sessions. I think there are some questions which are remaining, some participants have asked. So do we take those questions or we leave those questions? There are two or three questions I can see on the chat.
Ma'am, if you permit me quickly, I'll respond. The temporal clustering, some person has asked. Yeah. Basically, it is time-based clustering of cases where if you get 20 cases within a period of, let's say, 3 days, which is temporal refers to time and clustering refers to those cases. And I think the next question is on referral center for sending isolates for molecular typing. I think Vikas sir would be a better person to respond to that.
Currently, country doesn't have any specific, but ICMR has certain center for excellence or nodal centers which are there for specifically for the specific bacteria. Dr. Aarti is part of that network where SGPGI Chandigarh is also there and CMC Vellore is there. So, ma'am, would you like to specifically tell which bacteria can go to which place?
So very briefly, ICMR has a network. At present, only the participating centers are sending isolates. Or one is for quality control. So there are like 4 centers, one looking at enterobacterials, Pseudomonas, Acinetobacter, Salmonella, Staphylococcus aureus, and other gram-positive. So like this, there are 4 centers. And there are many regional centers. So they all send their isolates of interest or which are different from the otherwise, mainly looking at the antimicrobial resistance. So they are not doing the typing in that sense, but since they are also involved in some sequence typings, so it is possible. But right now, it's not like it's a center for typing that anybody can send, but I'm sure by talking to ICMR, Dr. Kamini Walia is the coordinator, it would be possible to characterize the strains of some interest, I'm sure. So I would request you to, anybody who wants, please contact ICMR. I'm sure they'll be happy to help.
And there is another question, that what is the best way to type Candida auris?
Maybe Dr. Chakravarti can later. Dr. Vikas may know.
Yeah. So for Candida auris, ma'am, whole genome sequencing, as we said, is the gold standard. But there are short-term tandem repeats. That kind of molecular typing is also available, which is being done for Candida auris, and people have identified outbreaks using that particular typing technique.
Yeah. ITS typing is done, and whole genome sequencing are the 2 very good techniques.
Yes.
Sorry to interrupt, but we are already running late, ma'am. Please.
Yeah, I think we should close the session.
Okay. Thank you, ma'am.
Thank you.
Thank you.
Thank you. Thank you. फोटो तो बड़ी अच्छी आ रही थी, हैं?
Good afternoon to all chairs and delegates. It's my pleasure to welcome you for this important session on antimicrobial stewardship and nursing. As you know, any battle requires soldiers to fight. Similarly, nursing as one of our soldiers to involve in fight against antimicrobial stewardship resistant and hospital infection. On the above note, I invite the chairs. First of all, Dr. Ujala Ghoshal, Professor, Head of Department of Microbiology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. She is also Secretary General of Indian Association of Tropical Parasitology. She is active in community work and deeply involved in current corona pandemic. Other eminent chair, Dr. Raman Sardana, Honorable Secretary of Hospital Infection Society of India. He is Head of Infection Prevention and Control, Senior Consultant, Interbus Apollo Hospital. Last but not least, the other chair, Dr. Haris Manzoor Khan, is eminent professor and chairman, Department of Microbiology, and along with that, medical superintendent of Jawaharlal Nehru Medical College, AMU, Aligarh. He is currently principal investigator of viral research and diagnostic lab. I would like chairs to introduce the speakers for this session. Okay, over to you.
Slide. Next slide. Requesting chairpersons to please introduce the speaker.
I request Professor Ujjwala to please introduce our speaker.
I think she's got disconnected because of network issues.
Okay, please, Dr. Harris, please introduce the speaker.
That is online.
So please introduce our speaker.
Should I introduce the speaker?
Yes, sir, please, sir.
I would like to introduce the next speaker, Mrs. Sandhya Rao. She is the nursing officer in charge infection control and waste management cell of Tata Memorial Hospital, Mumbai, Maharashtra. She has done a BSc nursing and diploma in oncology. She is also has been awarded the best nurse and also the first international certified infection control nurse in India. She has got a lot of other publications and achievements, and I would like to welcome her to this particular talk and invite her to start her presentation.
Good morning to one and all. Today I am going to talk about surveillance and monitoring IPC practices in TMH. Contents of my presentations will be these. Surveillance of hospital-associated infections, which is recording and counting of infections arising in the hospital. Elements of surveillances are data collection, analysis and interpretation, feedback, and intervention for preventive actions like root cause analysis and corrective actions. It requires dedicated trained personnel. Both clinical and microbiological data are essential, especially patients' records for the infection and microbiology reports. It is truly beneficial when the results are used to improve patient safety. These are the methods for the surveillance. Mostly, I will be going to talk about the targeted. I will be presenting some of the historical studies with the targeted surveillance. Why targeted surveillance? Because it is focusing with the objectives like specific events, process, organisms, and or patient population. According to niche, advantages are it allows standard definition of infection, makes case findings more accurate, makes more efficient use of resources, and makes risk adjustment possible. Most of the targeted surveillance done are site-oriented surveillances, that is site-specific, like VAP, SSI, CLAPSI, COTI, infections with the MDR bacteria, and outbreak investigations. Unit-oriented surveillance, like ICU, hematological units. Priority-oriented surveillances, and equipment-specific procedures like endoscope procedure and laparoscopic procedures. Surveillance of SCI, mainly there are 4, and this is VAP, that is ventilator-associated pneumonia. Most of the hospitals are following CDC criteria and definition for the VAP. Data collection is done monthly. Everyday data is collected from the ICU patient. Those are on ventilation. Once report is coming positive from the microbiology, it will be correlated with the patient signs and symptoms, and then it will be discussed with the intensivist, and that will be seen whether it is fitting in the CDC definition. And the statistics are collated on monthly basis to calculate the VAP rates. And then you get your monthly trends, like and then it will be calculated with the CDC formula. This is also targeted surveillance was carried out in our hospital, that is incidence of ventilator-associated pneumonia. Aims of this study was to audit compliance with the infection control practices in the ICU for prevention of VAP by spot surveillance, to detect the incidence of VAP and correlate with the infection control practices in ICU, and to identify the common organisms responsible for this VAP. According to the CDC, material and method was used. It was carried out for the 2 months in August and September 2008. 58 patients were enrolled. 200 observations were noted, and mean duration of stay was 3.5 days. And VAP 17 patients, it is 29.3. Same time, tracheal aspirations were sent for these patients, number 23, and 27 isolates were isolated. Acinetobacter was highest, 37%, followed by Pseudomonas, E. coli, and Klebsiella. This slide shows compliance of ICP observed in patients with the VAP who developed VAP, 23 observation, and without VAP, number 177 observations. If you see this violet color who have developed VAP, the compliances among this for the ICP is less. So conclusion was our study was that the incidence of VAP was high in ICU with the Acinetobacter and Pseudomonas being the commonest pathogen, and research shows that the simple infection control measures can play a large role in the prevention of VAP. These are the care bundles we are following in the hospital now. It is more than 15 care bundles in the followed, and our now rate is also came down. Bloodstream infection also is HIV. Again, here CDC criteria and definitions are used, and mostly CLAPSI we are doing in the hospital wide. For the monthly data collection, everyday data is collected from the patient who are having central line, and it will be according to the culture reports. If it is sent, it will be correlated with the culture reports, and then it will be discussed with the clinician, and it will be seen that it is fitting in the CDC definition. This is usually done. And then you get BSI trends, and it is calculated according to CDC formula. This is one of the CLAPSI data targeted surveillance done in our hospital, 16 February to 15th March 2021 for the PICC. All set performa as a CDC guideline, and it is followed. Total 100 cases were included. All medical onco patients with PICC were selected, and daily observation done for their signs and symptoms, their blood cultures reports, and are seen. If positive culture reports were discussed with our clinicians, and whether they are fitting in the CDC guide definitions is seen, and then calculated rates. Also, care bundles were audited weekly. Flushing and tracing was done, which is required for the PICC. So line days were calculated was 1,987 and culture positives were 8 it came, and 4.02 is our CLABSI rate. These are the isolates were isolated Acinetobacter 2, E. coli 3, Klebsiella 2 and Rhabdococcus 1. Also, we have done 50 cases were done for the central line, that is neckline of targeted surveillance. Again, it is done. All ICU patients with the central line were selected. Again, it is observed like culture reports, and it is when it is fitting in the definition of CDC, it is taken as an infection and discussed with the clinician. Also, care bundles were audited. And this is a rate for the central line that this was 3.52 for the rate, and 2 isolates Klebsiella were isolated. These are the central line care bundles are followed in the ICU, and you can see the non-compliances are very less. Also, central line care bundles are carried out in the hospital wide also. These are the 4 observations were done, and you can see average compliances are of IPC, these care bundles are 96. Again, RCA was done for the non-compliances, and corrective actions were taken. COTI, that is catheter-associated urinary tract infections. Again, CDC definition and criteria are followed for this. And again, for the monthly data, again, it is like it is daily. These patients were followed with the catheter, and culture reports were taken according to the, if it is fitting in the CDC definition, it was discussed with the microbiologist, clinician, and if it is fitting in the CDC definition, then it is calculated, taken as an infection. And ICU concludes whether this is catheter-related UTI in consultation with the ICT. And then you get monthly trends, that is, and it is calculated with the CDC formula. This is targeted surveillance done in our hospital, that is, and followed set performa as per CDC. 100 cases were taken. All surgical wards were taken for this observation. Patient with urinary Foley's catheter were taken. Again, signs and symptoms like fever, frequency of micturition, dysuria were observed. Daily follow-up done till the discharge. And lab data is collected for the culture sample if it is sent, and discussed with the microbiologist, clinician, and if it is infection, taken as a calculated for the infection. Also, care bundle were audited during this. And our rate is total Foley's catheter days were 616 days, and our rate is 4.87. Organisms were isolated, 4 in number, that is Klebsiella 2, Candida albicans 1, and non-albicans Candida 1. Also, we have these care bundles were 17 variables observed during for these care bundles, and these are the results that non-compliances are very less. And then RCA is done, and corrective actions were taken. In the worldwide also these observations were done, these audits were carried out, and you can see here average compliances is 90%. RCA is done for the non-compliances and trying to improve situation. Surgical site infection also one of the HI, which again we are using CDC guidelines and criteria for the defining all these surgical site infections. If you are doing monthly, you get trained for the monthly, and calculation is done in according to the CDC. This is one of the targeted surveillance done in my hospital, that is antibiotic prophylaxis in clean head and neck surgeries. CDC definition was used for this, and proforma set according to the CDC. Data collection followed, set proforma for as per the CDC. OT list of previous days surgeries were collected. All clean cases are taken up for this surveillance. All operation details recorded in the data format. First, second days post-operative. Patients were followed up in OPD after discharge, and inputs were taken from surgeon or from the EMR. 30 days after the surgery, even phone calls were done to patient for the delayed infection. If there is any pus or oozing from the site, a swab is taken from the site for the culture during when they are indoor. Culture reports are traced and discussed with the surgeon. Whether patients has been further treated with the antibiotic, and confirmed with the surgeon. The aims of study was to study the infection rates and role of antibiotic prophylaxis in clean head and neck surgery, and to establish system for the surgical wound infections. All patients were selected for this as a elective clean head and neck surgery. And injection cefodoxime 1.5 gram within the 2 hours of surgery was given. Type of surgeries were involved in this were thyroid, neck dissection, parotid surgeries, and others like parapharyngeal mass, STS neck, carotid bodies. Order of performance also observed, and median duration of surgery was 140 minutes. Blood loss, median blood loss was 170 ml, and median stay of patients was 5 to 6 days. And it was at the end of the month, it was calculated for the infection rate. So uninfected were 97, infected 3, and our rate was for this study was 3%. Literature review also done for this study, and internationally it is in 3% infection rate. And another study by the Fitrian reported a wound infection rate of 2.9%. Cost also estimated for this study. That is, earlier it was rupees 830 or 480 for the clean surgeries. During my protocol, it was 180 rupees. So in conclusion of this study was to acceptable rate of infection with single dose prophylaxis. Infection rate is not related to type of clean surgery. Also, surgical checklist was followed during this surveillance, preoperative, intraoperative anesthesia, trolley, postoperative, etc. So that was about the surveillances was of the HA. Along with that, this process audits also were carried out. So now we will move on to process audits, that is IPC with practices. So the objectives of these audits were to prevent the spread of infection by identifying and setting controls for possible source of infection, to monitor and evaluate infection prevention practices in a hospital, and to identify the scope for the improvement, and to provide valuable data to enhance quality improvement, and to satisfy regulatory or accreditation board. For this, roadmap was arranged, that was arranged competency-based training. After that, the audit was done, and then feedback was taken as a result. So these are the training modules were prepared, standard precautions, our housekeeping policy, the infection control manual, all this education was given to them by taking pre-op, pre-test, post-test. Some of the competitions of the poster competitions were taken, and then it was audit were taken. So audits helps to identify gaps and strength in infection prevention practices. We designed this methodology was used WHO, CDC, and Infection Control Nurses Association UK tools for the standard, and we trained 2 nurses for this audit. In 2019, pilot audits were carried out, that is pre-COVID period. So these are the audit list which were carried out during that period, and for the non-compliances, corrective actions were taken for and then RCA was done. And during COVID, we felt that we should be taking audits again, and whatever corrective actions were taken, whether it is implemented or not, that we wanted to check. So in 2020, planned result-oriented audits, that is COVID period. This is hand hygiene was the first audit, which is a quality indicator also. So WHO 5 movements tools were taken. It is done for 1 month from September 2020 to 25th September. All doctors, nurses, and ancillary staffs were involved. And WHO's 5 movement hand hygiene performance taken as a tool. Randomly 22 observations per category of healthcare worker was done, and all clinical areas were observed. These are the 5 movements we have taken. So comparison of WHO's 5 movements compliance among TMH healthcare workers pre-COVID and during COVID was observed. And actions are hand wash, hand rub, and this is the formula of for the calculation of rates. You can see results over here that pre-COVID, you can see so much scope is there for the improvement. So those we have observed during COVID-19 period, it is reverted. So much drastic change was there. It is same for the doctor. You can see over here pre-COVID, so much scope was there, and then during COVID, so much care was taken, and the drastic change we can observe here in the doctor's compliances of the hand hygiene. Also for the ancillary staff also, pre-COVID, there was so much non-compliances were there, whereas during COVID period, it is, you can see here, the compliances are high. Still, after touching fifth moment, that is after touching patient surroundings, the scope is for the improvement. After this, we have taken process audit for the hospital-wide and methodology use. 4 observations were taken in a month, once in a week. Marked as acceptable, yes, and not acceptable, no. And numerical values were given, yes for is 1 and no is 0. And overall compliances were measured with this formula. So this is first audit for the hand hygiene facility compliance TMH. Was, if you see, this is the perfect scenario for the hand hygiene, where you are having liquid soap is available at the point of patient contact, whether it is hand rub is available, whether hand hygiene is performed. All these points, there are 31 observation points were observed. And you can see the results. The average is compliances is 92. And these are the 4 observations per month, of course, were taken, and non-compliances were audited, and for the highest compliances, prizes were given. So this is RCA was done for the non-compliances, and we will be improving in this. Peripheral IVLized care bundles, 10 variables were observed, and especially our care bundles comes in picture. Average is 84 compliances. This is hospital-wide. And you can see lowest compliance, it is almost some of the areas, it is even 100% they have reached. And non-compliances, RCA was done. And again, improvement is seen. Environmental audit, 53 variables were observed, and we have very good system for the housekeeping, where we are using 3-bucket technique. We have schedule for the cleaning, that is morning, evening, and night, and weekly schedule thorough cleaning is done. And this is especially in charges are taking care of this. And you can see average is 93, where non-compliances, average highest compliances were given prizes, and non-compliances were done, RCA was done, and then it is taken care for the implementation. Appropriate use of PPE, personal protective equipments, total 13 variables were observed, like protective equipments are available, whether N95 respirator is used with the fit test and all, proper technique, sequence for the donning and doffing. So 13 points were observed. And you can see here, average is 95. And non-compliances were taken care of with RCA done. And highest compliances were given prizes. Isolation practices, again, it is 18 variables were observed, like patient placement, waste segregation, donning, doffing, hand washing, linen is disinfected, and our compliances came 100%. Maybe because of COVID situation, it is done 100%. This is knowledge assessment for the prevention of sharp or needle stick injury among staff, our staff, and that is placement of sharp containers, safe practices, policy awareness. Average compliances, if you see, it is 90%, and lowest compliances, RCA is done, and taken care for the their non-compliances for the corrective actions. So in conclusion, surveillance of HAI is integral part of effective hospital IPC program. Audits measures healthcare workers' compliance with IPC practices and can be correlated with HAI rates. Nurses plays an important role in surveillance program. It can be labor intensive and resource consuming, so thoughtful approach is needed. Basic surveillance can be conducted with large infrastructure, without large infrastructure. To develop a surveillance program for the first time, start slowly, gain experience, and expands as problems are identified and as resource allows this. Surveillance should be started with an infection risk assessment first. To achieve quality care, regular evaluation on practices, and its feedback to management is necessary. A satisfactory infection prevention and control practices require cooperation and commitments from healthcare workers. These practices will provide optimum protection for patients as well as staff. I would like to acknowledge Dr. Badwe, Director TMC, Dr. Pramesh, Director Tata Memorial Hospital, Dr. Jigeshu Divetia, HOD Anesthesia and HRCC Chairperson and his team. Dr. Sanjay Bishwas, HOD Microbiology and his team. Department of Nursing and Hospital Administration. These are the prize distribution. Those who have highest compliances, for that nursing in charges were given, and that boosts their enthusiasm more. Thank you very much for listening.
Sister, I'd like to congratulate you for your excellent presentation. You have given a lot of data and very interesting findings. And I think the most interesting finding is that due to COVID, the compliance for infection control practices has increased dramatically. That is very interesting. Before this, hand washing is always a problem, and hand washing compliance is usually shortcoming in most of the hospitals. But we have shown that because of COVID, that compliance rate has gone up to almost 100%. It's a very good presentation. Thank you so much.
Thank you, sir.
Thank you, Sandhya, for a very nice and lucid presentation. You have shown very well that you have also elaborated the role of infection control nurse and how useful they are for infection prevention control. And as Dr. Harris has a nice, your data has shown, you have shown a lot of useful data, and as has shown that each coin has two sides. So though we suffered a lot because of COVID, but as far as infection control measures are concerned, so adherence to that, as your data has also shown, has increased to a large extent, which is a very good thing. Thank you very much. Thank you very much for your nice presentation.
Thank you. Thank you.
So, sir, yes. Okay, sir. So, thank you, sir. Our next presenter is Miss Salini, and she is assistant professor in Amrita College of Nursing, Kochi, and she is a certified BLS and ACLS provider from 2017 to 2019, and she has various awards, as I said. And now I invite her for her presentation.
Good afternoon to everyone. Thankful to be in a great platform. My topic over here today is monitoring HCI outside the hospital. It is the time for community nurse practitioner in India. It is the time for them to monitor the HCI. So the first thing I want to tell to everyone is that after entering a hospital, the first and foremost thing to be noticed is the very first requirement in a hospital is that it should not do the sick no harm. Already they are sick, so don't do any more harm to them. Healthcare associated infections, or HCAI. This is healthcare associated infections were earlier known as, these infections are earlier known as nosocomial infection. We are learned in the prior medical things as a nosocomial infection. And this particular word the term was derived from Greek words like nosis, and that means disease, and comium means to take care of. Healthcare associated infection, or HCAI. Healthcare associated infections are infections resulting from medical care or treatments in a hospital setting, primary care setting, nursing home, or the patient's own home. That is how it has changed from the nosocomial. Priorly, it was known as nosocomial infections, and right now it is a wide setting as involved, like a hospital, not only the hospital setting, even the primary care setting, nursing home, or the patient's own home will be a source of infection. So the healthcare associated infection, and as a result of healthcare related procedures, any infection that is originating from hospital settings, primary care settings, nursing home, all the patient's own home will be the source in HCAI. So this definition, it is reflecting that the fact that healthcare has changed and is now often performed outside the hospital environment also. So it can affect any part of the body. So HCI has potentially opposed to get risk to patients, clients, and the staff arising from the treatment and care in hospital and primary care settings. So all are involved in this risk. The patients and even the clients who are coming along with them and the staffs who are involved in the care of health settings. So the main wide range of it is actually HCI covering a very wide range of infection and everyone knows about it. And the most well-known, including this particular infection, is methicillin-resistant Staphylococcus aureus or MRSA, which is very known one, and methicillin-sensitive Staphylococcus aureus, that is MSSA, and Clostridium difficile and Escherichia coli. These are the main one out of many one. In HCAI, the main ones involving are this. In this, there are risk factors. How we are getting out of this all bacteria, how we are getting is depends upon the risk factors. It may be with the whole setting, regardless of the resources available. Sometimes it is with the full of settings. Some factors which is presenting regardless of the resources available are prolonged and inappropriate use of invasive devices, antibiotics, high risk and sophisticated procedures, sometimes immunosuppression and other severe underlying patient conditions, insufficient application of standard and isolation precautions. So these all factors are present regardless of the resources available. There are resources available. Even with the resources, these factors will be working, and these factors will be giving a high risk for the patient to get an HCI. So some other risk factors, these are the more specific to the settings. I told priorly, HCI is not only restricted to a specific setting. And there is factors even present with the limited resources. There are also healthcare associated infections are present even with outside the hospital. That these areas are without much resources. These areas which are presenting with the public health areas at very low infrastructure areas. All these are with the specific settings with the limited resources like inadequate environmental hygienic conditions and waste disposal. Poor infrastructure, insufficient equipments will be there sometimes, understaffing will be there, sometimes overcrowding, and because the areas which how well we are controlling in an hospital will not be possible in the primary healthcare settings, which is with the very limited resources. So the poor knowledge and application of basic infection control measures. Sometimes the people of public healthcare workers maybe poorly knowledge about the basic infection control measures and lack of procedure, lack of knowledge of injection and blood transfusion safety, absence of local and national guidelines and policies. This all will be looking over as a risk factor. So the best thing to do control all this is a surveillance. Surveillance has been defined as a systematic collection, analysis and interpretation of data on specific events, infections and diseases, followed by the dissemination of this information to those who can improve the outcomes. So because when we are not measuring it, if we are not measuring it, we never ever can improve from the status where we are. So surveillance has been the purpose as systematic collection of all these analysis, whether it is happening or not, whether it is followed in that particular pattern with the infection control measures and interpretation of this data. After interpreting this data on specific events, infections, and diseases, followed by the dissemination of all this information. So this is a very important part in the healthcare associated infection prevention. So surveillance has that much importance in the method. So there are different methods for the surveillance. Like there is targeted surveillance are there, process surveillance are there. So targeted surveillance is mainly that is which type of surveillance we have to use depends upon the settings, whether it is a primary healthcare setting or whether hospital setting. So the targeted surveillance is aimed at high risk areas, that is the procedures directed to specific type of infections associated with high morbidity and mortality. So substantial reduction of HCAI that is possible only with the process surveillance. If at all we are doing a targeted surveillance, we can reduce the outcome or reduce the cases or the outcome we can achieve only through the process surveillance. So further reduction, we can get it with the root cause analysis of the preventable causes. Like if there is the preventable causes means we have to do the intervention for it. Then only we can achieve the, even though methods of self-surveillance are available, it will be achieving the outcome only through that method. So in any of these cases, situations, the body is compromised when the patient is coming to the patient area. The body of the patient is compromised. Okay, when they are coming to a primary healthcare center, when they are coming to a hospital setting, when they are coming to either they are their body immunity is compromised, otherwise they are coming for a procedure, or any other, they are coming with an infection. So in any of these infections, what happens is the body is compromised and is not behaving in the same way as a healthy body. So people who are ill on admission will be already having some immune compromising or underlying diseases, and the three infections can be caused by the bacterium or by viruses. So like basically they are either infected with the bacteria or infected with the infection. But we have effective resources to manage with the bacterial infection, but we have sophisticated with the viral infections because we cannot fight against with the, we don't have resources to fight against the viruses itself. So the types, so how we have to fight against this healthcare associated infection depends upon the type of HCA affected. So there are many types, but under that, the main important, which is frequently seen, are urinary tract infections, which is happening due to cystitis and kidney infections, lower respiratory tract infections, which is happening because of bronchopneumonia and lobar pneumonia, surgical wound infections, which is stitching, which may be related to the small stitches or surgery or surgical wound, and the skin infections, which is diabetic ulcer. It may be a diabetic ulcer or infected varicose vein itself, and sometimes very rarely it is going like a bloodstream infections, which is called as septicemia. Out of all this category, frequently seen cases are under urinary and respiratory tract infections, which are the most commonly seen HCI healthcare associated infections. Urinary and respiratory tract infections are more common. So risk to acquire an infection or to be worse, it depends upon how they are or to whom they are getting and in what situation they are getting this infection. So the sicker patients becomes more prone to get the infection. So their immunity is already compromised. If the cancer patients are coming, their immunity is already compromised with many reasons, including the chemo radiation therapy. And sometimes very young patients, their immunity pattern is not properly developed. And patients who are receiving treatments with the certain kinds of drugs which suppressing the immune system, like steroid drugs. So these people are highly prone to get an infection through this method of healthcare associated infection. So some surgical procedures more likely to result in an infection than others. All surgeries are not causing, still some particular surgeries, category of surgeries are getting more chances, like the main way, like gastrointestinal tract, which is causing of surgeries related to gastrointestinal tract. What is happening over here is bacteria from the non-sterile sites may gain access to the sterile sites, while we all know that inside the intestine naturally growing bacteria are there. So from the non-sterile area, they are getting access to the new sterile areas through the surgical procedure. And these people are adding, sometimes, not only this, the implants which they are using, some bacteria are able to stick on this plastics or the material which they are using as an implant and to get an infection to the new site. So these are some surgical procedures which are getting more chances to get a HCA, mainly GI tract infections and some type of implant. So the impact after getting this infection, the impact of infection, how the impact will be showing. Infections may be ranging from mild to severe, and the impact will be forbidding. So it may be complex side effects, including all HCIs may not be causing mortality, but there are cases which is ending up with the deaths also. So healthcare associated infections never ever considered as a simple one. We have to consider it as a major thing which has to deal it with a more seriousness. Why means the healthcare associated infections are causing a big burden for the economic system. So some kind of infections are more serious than other. That out of this serious infection, which include septicemia, that is one which is causing blood infections and causing entire organ damage. That is one most important and serious one, which is even causing a mortality. And other one is a urinary respiratory tract wound or skin affected HCAS. They are more serious comparing to other HCAS. So the kinds of bacteria that is causing the healthcare associated infections are more commonest. That is the commonest viral cause of healthcare associated infections, probably usually norovirus. That is in case of public health areas, this is an outbreak of winter vomiting disease of every year. And like this is usually reflection of a community outbreaks spilling into the hospital and spreading within the confines of hospital. The people are coming from the community and they are having that particular condition. They are coming, but they are not showing any symptoms. But these people are colonized with this bacteria. And when they are coming to the hospital for any procedure or surgery, they are more vulnerable to get the infections with the colonized bacteria which is outside, existing outside. So how we can diagnose it? That is healthcare associated infections. How we can diagnose is one thing, how the patient is showing the symptoms, like symptoms, redness, swelling, heat over the area, or sometimes pain and even fever. These are the clinical symptoms which we can identify to diagnose such symptom. HCI. Other one we can do also with the samples, laboratory samples, to monitor the which type of infection existing over them, and it results from the different patients collect because all the patients may not be exhibited with the same bacteria, but it is very good that after getting many patients data or the bacterial information, you have to gather it all to monitor which one is going higher, whether it is the urinary tract infections are going up, whether it is a respiratory tract infections are going up high, to know that it will be healthy. So it is very important to remember that people can vary the bacteria harmlessly. They can carry the bacteria harmlessly because they are not showing any symptom, but that doesn't mean that they are not infected. They are colonized. Okay, they are highly colonized without showing any symptoms. So it is very important to take a simple precautions that we all know. What are the simple precautions? Like a hand washing, and in our right now situation of corona virus, we can go for a hand rubs because it has more benefit comparing to hand washing right now. It is more accessible and mobile, and we can carry such sanitizing bottles. And even handkerchiefs to cover, and it is prior situation when we can carry the handkerchief right now. As a must, we have to go for a double masking because of corona virus as a variants are started like a lambda. And prevention of healthcare associated infections, how we can prevent it, because this is a very important factor. This is all existing, and we all know that this is existing. These are the main kind of bacteria which is existing, and this is the way we are getting the infections. And a very important point is how to prevent this infection. The majority of infections we cannot prevent it. About 15% of healthcare associated infections, but we can prevent also. So the one which we can prevent, we have to take the full access to control that, because a healthcare associated infection will be crossing the infection, that is bacteria is transferred from one person to another. So this is as a process, even the patient is going out of the hospital and in the community it is spreading, and as a colonized format it is going inside their community also. So even the majority you cannot prevent, 15% you can prevent it, which is possible that we have to make it practical. So the role of hospital, how in hospital it is easy because we have a strong infection control team for it. So the wide range of procedures, practices, and we are updating our staff nurses, doctors, and all healthcare related workers in relation to the infection control measures. So it includes the contamination of equipment, single-use instruments, isolation facilities, hand hygiene, very importantly hand hygiene, and the sterile surfaces which we are using in the theaters. But it is very helpless. Okay, in the community, it is very helpless. Okay, so if you are not doing it, like if you cannot measure it, you cannot improve it. As I told, this importance of surveillance is very important, and it is very important in the public health area. So the surveillance is a very essential component of infection control programs, and it is the main aim, because through this main aim surveillance program, what we are doing, we are identifying where it has started outbreaks and establish a baseline rate of infection, how many people are infected. And the starting of corona infection, we have done it effectively, and even effectively it has, as I am a person from Kerala, I can very proudly tell that during the time of Nipah virus infection, they have done it very effectively and they could prevent it in a effective manner. So ultimately, we are achieving reduction of all preventable healthcare associated infection. I'm not telling Nipah is an healthcare associated infection, but with this effective surveillance program, they could control it. That is what I have told. Since surveillance is an expensive, but while hearing surveillance, it is easy, but surveillance is a very expensive and very time-consuming exercise with a lot of meta work which is needed, and a lot of meta work with the manpower needed thing. So the surveillance of healthcare associated infections, especially in a primary health setting, how we can do. The main characteristics of effective surveillance is based upon sound epidemiological and statistical principles. So the data are properly collected. First we are collecting, and then we are analyzing, and the information is shared timely in a manner to control the infection and to continue effective infection control practices in a quality care center. And efforts to improve the practices and decrease healthcare associated infections in a critical part of surveillance plan. This is actually the main characteristics of effective surveillance. I already informed there are many types of surveillance, outcome surveillance and process surveillance. Out of this, the process surveillance has got a more importance. Monitoring of specific HAI include outcome surveillance, and process surveillance is monitoring of patient care practices, because not only in hospital, even in the public health service. So monitoring of patient care practice, including their infection control practices, while they are taking care of patient, while they are dressing a patient, when they are providing, while they are starting a prophylactic antibiotic, during the surgery, and the use of aseptic technique, while even in the insertion of the invasive line, it is important. Another two methods of out of these types of surveillance, another two methods is continuous and periodics. Continuous, it is a data collected continuously in on this basis, and periodically we have to do the quarterly plan or a yearly plan or a monthly plan for this particular thing. So the active surveillance is identification of healthcare associated infections by trained personnel. So that need a lot of skill. The trained personnel is needed to do the surveillance in a effective way. So who proactively look for HAIs using multiple data sources. Active surveillance is conducted by trained staff nurses using standardized case definitions. If you are doing active surveillance, we need to have a trained staff for it and with a accurate plan and than a passive surveillance. So the passive surveillance of healthcare associated infections are referred to identification of HAI by patient care providers. So the passive is through the patient care providers such as physicians, nurses who may not be formally trained on surveillance but may be consistently use the standardized surveillance case definitions in relation to that. And this is very important part, and who will be the in charge, important why I'm pointing out the people who are doing it, it is surveillance is a very important part to prevent the healthcare associated infections. So what are the purposes of conducting surveillance in a healthcare associated infection is the first one, it determines the baseline rates of how much rate it has got healthcare associated infection and identify and occur the infections above the baseline rates and detect and report the notifiable diseases to the public health authorities and detect the investigate clusters where it happened. Even in corona, more people are infected in a particular area. We are just closing the entire area, and we are even advising for a triple lockdown. The same way, in surveillance program to detect and report notifiable diseases to the public health authorities, detect and investigate clusters and outbreaks where it has happened and what is the way of exposure, including the emerging infections, diseases, we can do with the effective surveillance program. So the process of surveillance will be helping the infection control practice team to do it as effectively. So observe the healthcare workers' practices. If you want to do this surveillance in an effective way, what you have to do is observing the healthcare workers' practices to ensure the compliance with the policies and best practices. Even though we are learning it, even though we are doing it, sometimes we may go out of it, the procedure. For that, to avoid that such a mistake, we need to go for a continuous retraining and retraining for the practice people who are involved in the healthcare and also observing their practices in a while they are dealing with the patients and provide information to the health guide which will help the guide performance improvement activities, assess the effectiveness of infection control measures, and meet the safety standards required by the health department and other regulatory agencies. So these are the main important things. Process of surveillance will be helping the infection control team in this way. Like the first one, it will be helping to observe the healthcare practitioners' way of doing it and providing information to help and guide their performance, how they can improve and what is the method they have to change according to the recent scenario and assess the effectiveness of their recently existing infection control practices and meeting the safety standards required by the health department. Some newly evolved infections need a change in their health infection and control practices. So these all they can advise through the surveillance program. So issues and challenges.
I would like now to invite Mrs. Mahvish Masi. She's a nursing tutor, College of Nursing, JNC, AMU Aligarh, and she has participated in the organizing educational programs. I would like now to invite Mrs. Mahvish Masi to present the talk.
Highly respected Professor Tariq Mansoor sir, Vice Chancellor, Aligarh Muslim University. Sir is the chief patron. The respected patrons, Dr. T.S. Jain sir, President, Hospital Infection Society, India. Professor Rakesh Bhargav sir, Dean Faculty of Medicine, JNMC. Professor Shahid Ali Siddiqui sir, Principal and CMS, JNMCH. Organizing Chairman, Professor Haris Mansoor Khan sir, Bursa. Professor M. Shamim sir, National Organizing Secretary, Dr. Raman Sardana. Organizing Secretary, Dr. Fatma Khan. Joint Organizing Secretaries, Treasurers, Joint Treasurers, WAB Advisors, IPs, Doctors, Medical Administrators, Nurses, ICNs, CSSD Managers, Healthcare Quality Personnel, Healthcare Engineers, and all the other audiences and participants that we have today with us. A very good afternoon to all of you. Firstly, it is my privilege and I'm being honored to have the opportunity to speak on this very important topic, which is infection prevention and control, a routine nursing practice or an extra burden. In the last many years, there have been many discussions held on infection prevention and control. But in the last 2 years, especially, we have seen a huge spike in the number of discussions held on infection prevention and control. Before we begin with the topic, I'd like to thank and congratulate HISI for their emphasis on the role of nurses in infection prevention and control. We know that nurses are working in close contact with the patients and are key role players when it comes to functioning within a ward, within wards or care units in a hospital. It's great that we are discussing antimicrobial stewardship and nursing together. Now, moving to our topic, which is, I'll again repeat it, it is infection prevention and control, a routine nursing practice or an extra burden. Now, we know that infection is the most leading cause of preventable deaths in hospitals every year. There are a large number of deaths reported because of nosocomial infections around the world. And if we listen to CDC, that is Centers for Disease Control, they too have estimated that about 1 in every 10 patients, they're affected with hospital-acquired infections. So this, if we see on a percentage scale, we can say that about 10% of all the patients that are admitted in hospitals around the world, they are affected with nosocomial infections. And we know hospitals are centers that treat and heal. Patients come to hospitals, they meet doctors, nurses, healthcare workers to get their health promoted, or they come to get treated for the already existing condition that is there or that they're facing. But no patient would expect to receive a new infection from the hospital, because hospitals, as I said, are centers that treat and heal. So we do not want our hospitals to be known for spreading new infections to the patients. Now, this also tells us, or we can say this also adds another point towards the importance of having IPC policies in our hospitals. Now, what is IPC? What is infection prevention and control in general? IPC refers to policies used to minimize the risk of spreading infections, especially in hospitals and other healthcare setups. Now, infection prevention and control is inclusion of policies or protocols or measures that are taken to minimize the risk of infections spreading in hospitals. Now let's see what WHO has got to say about infection prevention and control. They say, WHO says it is a practical evidence-based approach which prevents patients and healthcare workers from being harmed by avoidable infections. Now, very important note here is that this in the beginning they say that it is a practical evidence-based approach, which means that there have been studies done, there have been researches conducted that have results or outcomes that tell us that IPC is effective. And effective in what sense? It is effective in preventing patients and healthcare workers from being harmed by avoidable infections. So there is no doubt whether IPC is effective or not. It is what the WHO is saying. And another very important thing to note here is that it prevents not just the patients, but also the healthcare workers. We are discussing about nurses today. It is also preventing the nurses or the healthcare workers from being harmed by these avoidable infections, those infections which could otherwise be avoided. So if we talk of the beneficiaries or who are getting benefited by implementation of infection prevention and control in our hospitals, and it is not just the patients, it is also the healthcare workers or our nurses. So IPC is not just for the good of the patients, it is also for the welfare and safety of the healthcare workers, be it our nurses here. Now we will try understand certain points that are telling us the advantages of having IPC policies in hospitals. And of course, hospitals that do not implement IPC, they are going to lack these points. So now we're discussing the advantages of having IPC policies. The very first being improved patient care. Of course, the most above all is a patient, or we can say that IPC directly improves patient care. This is because firstly, there is reduced risk of patient receiving nosocomial infection. Then also the healthcare workers are getting that confidence, and they know that they are working in an environment where they are safe, or they will be prevented from receiving any infection themselves. So there is a better approach towards the patient, and overall there is an improved patient care because the doctors, nurses, and all the healthcare workers, when they're working in an environment which has IPC implemented, they are more freely able to do a more dedicated job towards their patients. Now, second point, it is shorter hospital stay. Now, if anyways, unfortunately, any patient gets an HAI and gets some hospital acquired infection. So this is going to prolong the stay of the patient at hospital. And this is also going to increase the burden on the healthcare workers. Talking of the burden, we are here observing that implementation of infection prevention and control is actually reducing the burden, because it is actually taking the burden off the shoulders of our healthcare workers by limiting the hospital stay, right? Because if there is any nosocomial infection, if the patient catches, then it is going to prolong the stay at hospital. So by implementation of IPC, you're preventing nosocomial infections, which is going to reduce or prevent, we can say, it is going to prevent the prolonged stay at hospitals. Now, third is tackle antibiotic resistance. IPC helps tackle antibiotic resistance. Antibiotic resistance or antimicrobial resistance is a problem faced by many doctors and many nurses, many hospitals, and it is growing with the time. And we know nosocomial infection is one of the leading causes or the factors that are finally contributing towards antibiotic resistance, because of nosocomial infection, or because of these infections, and there is increased usage of antibiotics, and as a result of which there is developed this antibiotic resistance. If these nosocomial infections are prevented, then the doctors, the nurses, the healthcare workers, they get a wiser choice of usage of antibiotics. They can make wiser decisions on administration of these antibiotics, which is going to reduce antibiotic resistance. So IPC helps prevent nosocomial infections, which is going to reduce the overall incidences of infections, and then it is going to help control the antibiotic resistance issue also. Moving on to the next point, which is prevention of spread of infection to the healthcare workers, the nurses. This is very important. As we were discussing also under the definition given by WHO, definition of IPC given by WHO, there we learned that IPC is not just for the good of the patient, but it is also for the welfare of the healthcare workers, and which is also going to take us to our next point, which is safeguarding the families of the healthcare workers. We know that infection works in form of a chain, and we need to break that chain in order to prevent infection from spreading. So we know if a healthcare worker is affected with a hospital-acquired infection or with any infection within the hospital setting, he or she can pass that on to his or her family members, and the family members of these healthcare workers can potentially pass this on to other people in the community they are living in or in the society. So if we are preventing our healthcare workers, if we are safeguarding the healthcare workers through IPC, we are also safeguarding the families of the healthcare workers, and through that we are also safeguarding the other people in the society. So we understand by this that IPC, or infection prevention and control, its results or its effects are not just limited within the hospital setting. They're actually also a kind of a service to the public health or the community health, which is a big point here to be noticed. I'll again repeat all the advantages that we discussed, which is advantages of having IPC policies in hospitals. It is improved patient care. Then there is shorter stay at hospital. Then it also helps tackle antibiotic resistance. Then there is prevention of spread of infection to the healthcare workers, the nurses, and also it safeguards the families of the healthcare workers, and in turn is helping us serve the society. So especially also, I'd like to mention here that in this time of pandemic, we have come to realize the importance of breaking this chain. We've seen many healthcare workers, they unfortunately acted as carriers of infection, and we have come to realize this even more, that it's important to safeguard the healthcare workers so that we can safeguard the families of them and thereby the society. And also healthcare workers are very important people in the society because they are the ones looking after the health of the whole society. So it's very important to safeguard the healthcare workers, and IPC, that is implementation of this infection prevention and control policies, is not just for the welfare of the patient, but also it is safeguarding the healthcare workers and thereby safeguarding or preventing the infection from spreading to the society. So these were the advantages that we discussed, and let's look at the other side of the coin, because despite of all these advantages, even after knowing all these points that are telling us that IPC is no burden, it is actually a blessing, but still there are going to be some people who will say that it is an extra burden to them. But why do they say so? It is sad that a very few might still say that IPC is an extra burden, but what is the main causative factor behind? Now, there are many issues that come with any policy that if it is implemented in hospitals or any setting. But what are the main factors that are actually making the nurses or the healthcare workers feel IPC as a burden to them? It is actually the poor nurse-patient ratio in hospitals. what happens is that, especially in a government setups, we see many nurses single-handedly administering drugs to 40, 50, 60 patients, which is a huge number for a single nurse to handle. And in one stretch of a shift, in that time of their duty hours, they have to take care of these many number of patients, which is already a kind of a workload for them. And amidst all that, if they're given under other policies, let it be infection prevention and control, so practically they experience it as a burden. I'd like to share this to you people. I'm not sharing any officially conducted survey data, but I spoke to some nurses in a hospital, that is GNMCH, and I also spoke to some friends of mine who are serving in various hospitals in a country. I spoke to them regarding this, whether or not, or how do they take this IPC, whether they consider it as a routine practice or an extra burden. I'm happy to say this, that about 100%, or I should say about all of them, said that they consider IPC as very important and a routine nursing practice. All of them said, all the nurses I spoke to, they said that they know that IPC is to be considered as a routine practice, but the problem is that when they're actually performing it, or when they're actually performing their duties, they are facing a lot of problems associated with it. And nurse-patient ratio, poor nurse-patient ratio is the most common of all those issues. And this means that the nurses, the healthcare workers are realizing the importance. They know the importance of IPC. They know that infection prevention and control is a must if they want a healthier society, if they want healthier results out of hospital settings. But the problem is when they're actually performing, when they're actually experiencing it, they experience it as more of a burden. So it's very important that we find out those issues and eradicate them. Considering all these things, we discussed a lot of points that are telling us that it is a blessing, and we also went through the other aspect which tells us that it is also kind of a burden. But above all, considering the points that we were discussing under advantages of IPC, they are important enough to come above every point. So it's clear that to have IPC, to have infection prevention and control is very important, and it is no burden. And as I said, when I spoke to these nurses, I learned, and I'm very happy to say that all of them said that it is a routine practice. It is to be considered a routine practice, though there are some issues with it, but they know and they realize that infection prevention and control is a routine nursing practice and it is no extra burden. So how do we conclude? Looking at the brief discussion we had and knowing that it benefits not just the patients, but also the healthcare workers, that is the nurses, their families, and society on the whole. IPC is definitely no extra burden, but a routine nursing practice. So realizing everything that we discussed, we realize and we conclude that infection prevention and control is no burden. It is a routine practice. The thing is that we need to keep having these discussions on IPC. We need to have these discussions continued until the time we have IPC well instilled into the core of the working systems of our hospitals. Because when it is well instilled into the working systems of our hospitals, then all these issues that come along with the implementation of such policies, they too will be eradicated. Then the healthcare workers will be more easily able to allocate their time and all the other resources and resources while working in the hospitals. So how do we conclude? As I said, I'll again repeat our conclusion that it is infection prevention and control, no extra burden, but a routine practice. I repeat, infection prevention and control is definitely no extra burden, but a routine nursing practice. Thank you.
Start.
Thank you for your talk, Mehmet. And I think it's very important that we emphasize on IPC. And thank you once again.
Thank you very much, sir. Thank you.
Thank you, Mavish, for a very
Thank you,
nice.
ma'am.
It was really a very nice presentation, and you have beautifully shown that it is really not a burden but a necessity, and it is a day-to-day thing that we all
Very
must
much.
do. Yeah, and I enjoyed your presentation, and your you expressed your views very. Thank you so much.
Thank you very much, ma'am. Thank you.
Now, sir, should I introduce?
Yes, yes. Please go ahead.
Sir, so our next topic is the CSSD and Operation Theatre. The topic has already, it is about the CSSD and Operation Theatre management, resurgence of a tradition or bifurcation of professions. And our presenter is Dr. Sneha Vaidya. She is Director Nursing from Apollo Hospital, Navi Mumbai. She has more than 25 years of experience in the field of nursing, of which 13 years in nursing administration. As regards, she has various awards and publication also, and she is a NABH SSS and PhD guide for JJT University Hospital Administration from IIM Ahmedabad. Now I invite her for her presentation. And then we have also have Ms. Gauri Parmanand Bhatia. She is a consultant CSSD and infection prevention. She's and her major achievements include, there are many. So to summarize a few, Brother Harman scholarship from Purdue University, Pennsylvania, and during accreditation and quality audit CSSD, she was declared as the best. It was declared as the best department. She's a visiting faculty for PG DHA and working committee for CSSD guidelines and reuse of SDU's guidelines. She actively involved in the biomedical waste audits, trainings of the contract employees, and treatment side supervised visits. She has around 34 years of experience in CSSD. Now I invite them for their presentation. Thank you.
Just trying to share my presentation. Just a moment, please. Yeah. So coming to the presentation, I'm really thankful. At the outset, I would like to thank Madam Captain Usha Banerjee, who is our Group Nursing Director for Apollo Hospitals, who has given me this opportunity to be in this forum. And I'm so happy to share the same platform with Gauri, because we have worked in the previous organization, and a lot of good exchange and good vibes of lot of values that we had in the past. Thank you, and happy to see you, Gauri. So starting with the presentation. Yes, if OT is human being, of course, CSSD is undoubtedly its hands. I can say that OT being the most prized customer for CSSD, it's natural for CSSD to comply the OT functioning, processes, schedules, and needs. And one depends on each other. It's like a symbiotic relationship, and you can't get away with that. We know that. I always call that OT and CSSD is like, it's like in one umbrella, and it fits very snugly into one umbrella. So working as a single unit with a very common objectives, you will always see the surgery definitely has to be under sterile conditions. Sterility and infection control, definitely it has both a common aim. The goal becomes the area of comfort and continuity and control without compromising the organizational goals. Maintenance of the sterile pathway is definitely a common duty between both the departments. Usually you will see that there is a need for these two departments to always communicate. And it is so essential, and definitely it is a need of the hour. And you will always see that this communication between two of them brings a lot of progress during the time of surgery, and which is very, very important. So you will see the coordination between whether it is a sharing of an SOP or count of an instrument set or availability of instrument at the scheduled time, or whether it is a new or condemned tools and urgent need. You will see a amalgamated relationship between an OT and the CSSD where they work together. And in fact, I will call that they are like two sisters of a department. There are different advantages, which I always felt, I have seen it through. One is effectiveness, especially, which is one of the biggest nightmare of a surgeon when he sees a post-op complication and he starts suspecting whether it was an infection or whether it was the infection control protocols which was not followed in a CSSD, or whether it happened during the intraoperative phase. So where you will see that the main engine that makes the OT and CSSD to earn for perfection, as there is no degree of sterility, and which we all know that an item is either sterile or non-sterile. It can never be called as relatively sterile or maybe partially sterile. There is nothing a term as such. So this prime objective will make the entire medical and nursing technical team to work more effectively. So that I call it as one of the advantages. Second advantage is the efficiency. It's a common observation of practice to see the efficiency of surgery, whether it is scheduled, a patient preparations, where OT and CSSD will join hands in planning and initiating this whole process of I can say the series of events that takes place in the OT. So what happens is when there is an amalgamation of these two departments, you always will see there's a lot of saving that takes place, whether it is manpower, whether it is your infra, energy, time. This all works together in the favor of the organization, and I can tell you. And what happens is, if you have to go even to a surgical sets that are maintained between OT and CSSD, you will find very less linear opportunity for a deviation of arrangements. Obviously, it goes via teamwork, because what happens is there is a thorough exposure, long expertise, I can say, or staff is ready to act, and any emergency that walks into your theater is definitely managed both, because there is such a unison understanding of both these departments. An improved communication will definitely build a trust factor. And I can always say that when you have a teamwork of in CSSD and OT, the person or the people who really get a good advantage of this whole situation is the surgeons, because then the dependability of both the departments become, the headache for them to manage this department becomes less. So this is one of the advantages I would talk about it. Now, what happens is when these two departments work together, they have common organizational goals. Obviously, you will see the turnaround times of getting the sets on time or getting it controlled is controlled and reduced. I can talk. Specifically, they work on cost consciousness, because what happens is the CSSD is aware about the number of wastage that would happen depending upon the number of consumables that are, or number of the monthly consumptions that they would talk about. Definitely, you're reducing your waste of time in case of an emergency or immediately when you require the manpower and infra. You have an improved efficiency between both these departments, because both are parallelly working and both are responsible towards the organizational goals. At the most, you will also see that it leads in a very organized and a controlled approach. And in the end, what are you trying to understand, or what do you want to get from both this department is nothing but the best clinical outcome. And what do you talk about best clinical outcome is decreased, I can talk about decreased intraoperative infections. That is so vital of its kind, I can say. And therefore, of course, you have better revenue results. So because when you have these two departments working together, you'll always see that your average length of stay or your infection rates are definitely under control. Of course, there are other parameters also that are like, a low hanging fruit to the infection control that happen in the organization. But this, I'm talking specifically from the surgical point of view. To conclude, I will say that coming together is a beginning, keeping together is a progress, and working together is a success, said by the famous Henry Ford. Yeah, thank you. Thank you so much. Hand over to Gauri. She can talk about her.
Thank you, Sneha. I thank all the organizers. Good evening, everyone. Good evening, my dear colleague Sneha, with whom I have worked together. Good evening, all the audiences. Can I share screen now? Sneha, I have to stop sharing your screen.
I've done.
Thank you.
Yeah.
Can we all see my screen? I request.
We can see. We can see.
Okay, thank you. So I'm also of the same opinion that even though we go for a bifurcation of professions, there has to be a very good coordination between these two departments. I'll begin by defining what's profession and professionalism. Profession is something for which you have been prolonged, you have got a prolonged training, and you have a formal qualification to understand what's to be delivered. And professionalism is all about competence and skills, which definitely comes with practice and over a period of time, the experience. What's the history? As early as 1903, that was in post-World War II, American College of Surgeons recommended that processing of sterile supplies that are used for patient care should be done by a dedicated team, not burdening the nurses, because that distracts them from their main focus of patient care. And as early as 1973, in India, we had a first formal CSSD. So I just want to convey that it is over 100 years around the world and over 50 years in our own country, we have already realized that we need a dedicated team who's trained in this kind of work. And from there on, how has this concept, again, I'm using the word concept because even if you do not have a CSSD, that's like depending on the size of the institute, but it's definitely a function that has evolved since then. Compatibility with technology. Initially, we had a lot of material that was compatible with steam sterilization, but that's not the case now. With modern technologies and advancement of procedures, we have got many other material like cameras, scopes, batteries. All those materials cannot be sterilized by steam sterilization. So you have to know about many other alternate technologies with which this material is compatible. Not only that, you have to know about how to select the equipment, how to validate that equipment. And apart from operating room, you have many other critical care areas like IVF, AKD, chemotherapy unit, wherein all these sterile materials, sterile patient care supplies are used, and a team has to have a knowledge of all this material that's getting used in the hospital. Continuous quality improvement is the ongoing process, and inventory management, as my dear colleague also mentioned, that inventory management is a very, very important function of any patient care area and the service department who's supplying with them with all this material. it has to be very efficient. No outdated inventories have to lie. At the same time, you have to have sufficient material so that the services are not delayed. Operator and patient safety, it goes without saying. In hospital, these two areas are very, very important, as other nurses have also mentioned. So all this becomes a part and parcel of any service department who is strengthening the direct patient care providers. Documentation, we all know the definition, that if something is not documented, that is considered in future as not done. Similarly, record keeping, unless and until you have a proper record keeping, it becomes very, very difficult, especially in case of medical legal cases, to prove whether the adherence to the standard operating protocol was maintained or not. Education and training. May in any department, like in any other department, CSSD or the team who's performing the job of CSSD, it becomes very important that they are coping with the newer innovations. As I mentioned, there are many other medical devices which are used nowadays. You have to learn about usage, you have to learn about dismantling, assembling, and using these devices along with maintenance of its functionality. Similarly, material tracking details, which set was used on which patient and how many turns is a particular device used. Quality assurance is, of course, an integral part of processing. Efficiency, as we kept mentioning, that efficiency is very important. Otherwise, we will not be able to manage the operation. Another very important function of the mental students happen. I'm sorry for the technical glitch. Sterility maintenance is equally important, because once you have sterilized the material, it has to reach the end user as it was at the time of taking it out from the sterilizer. Collection and distribution is another very important function, because there are many departments in the hospital from where the used supplies have to be collected following infection prevention practices. And similarly, all the sterile material needs to be delivered at their doorstep following infection prevention practices to maintain the sterility. Administrative functions of CSSD include management information system in terms of consumables, in terms of the instruments utilization, in terms of the budgeting. What next, what is going to be included in the next financial year's budget, and how is it justified? Similarly, industrial relations, whenever we have people who are working as a team, somebody has to manage those industrial relations and the attrition rate, because we know that as soon as people get trained, they are always waiting for the better opportunities. So all this also has to be kept in mind. Otherwise, the training and the time spent on training is it's becoming a liability on the institute. Adherence to infection prevention protocols, and moreover, liaising with the external authorities. When you have a sterilizer and that has boiler, you have to follow all the let down safety aspects of boiler safety. Similarly, when you have gas sterilizer, there are many environmental control measures that come into picture. So you need a dedicated person to look after all these areas. So I would conclude, when hospital was made a part of healthcare industry, it became very prudent to have efficient and sustainable operations, and resource allocation will be on the basis of assigning and managing the resources to achieve the strategic goals of the institute. Cost benefit analysis are to conform to measurable financial metrics, and business will definitely be defined as serving the purpose and generating value for all the stakeholders, namely patient, community, healthcare providers, and the board of trustees or the top management, or we can say a company who's running the hospital. Thank you so much.
I would like to thank both the presenters. They have presented very well, and they have really stressed the importance of CSSD. The CSSD, somehow they are always in the background. They are never in the forefront. But actually, it's their efforts as a result of which you have successful surgeries and you don't have infections. So really, you have really emphasized the importance of this particular section of the hospital. Thank you so much.
Next slide.
I would like to introduce Dr. Leena Mendiderata. She is the Senior Consultant Microbiology and Infection Control, Intrapress Apollo Hospitals, New Delhi. And I'm sure she must have a lot of experience in this particular field. And I would like to invite her for presenting her.
You are muted. Am I audible now? Yeah. Okay. Namaste, everyone. Thank you. And a very special thanks to my teacher and mentor, Dr. Raman Sadana. For out here, we have the luxury of being under his constant guidance all the time. My earlier speakers have actually so elaborately and so beautifully penned down everything. Just some salient features, what they said, we'll just highlight those. The first speaker very beautifully captured all the surveillance parameters and each and every concept, the CLABSI, VAP, COTI, SSI, the criteria and how to be carrying out the surveillance was very well done. The second speaker to do about community nursing very well highlighted the fact that it is actually the endogenous flora which is responsible for the maximum type of infections, and majority of them are actually caused due to the endogenous flora. That is something which we keep on teaching day in, day out. The third speaker, very well presented and very well talked about it not being a burden actually. And I think we should actually be celebrating the concept that nursing have so well evolved and stood up to the infection control practices, infection control itself is such a rapidly moving era, especially with the COVID and so many situations. So the nursing community have stood up to it so very well. CSSD and OT, of course, they are very integral parts of nursing, and I mean, without them, it is actually a zero. The infection control practices are actually a zero, because that is the heart. That is what we say. CSSD is actually the heart of infection control. So very well coined out. And with that, I'll just, I know time is actually running out, so I will be very brief, and I will just try to just give some thoughts on the actual theme of this session, which is to do with AMS and nursing, antimicrobial stewardship and nursing. So when we were discussing through the entire sessions, we did touch about various parameters, various facts related to antimicrobial stewardship. And I think the role for nursing in antimicrobial stewardship actually starts from the diagnostics itself. When you talk about, let's say, collection of samples for cultures, you want to generate a good report. We all know how important it is for a sample. So for us, if we are in the lab, it is actually the bedside nursing who give proper instructions, be it for the collection of sample, the paired sample collection for blood culture, or sampling for defining UTI, so how the asepsis is defined. And not just that, timely transporting of the samples to the lab. So actually that is where the role for the nursing and the antimicrobial stewardship actually starts out. Again, chasing the reports, the physician is either too busy with everything, and he would not have the time to actually sit and look at all the reports. So it is actually the nursing who brings it up to the clinician, and actually is chasing the reports and communicating to the treating team. And not just any report, in fact, even the critical lab reports, something like a positive blood culture, or let's say a procalcitonin, a very highly elevated procalcitonin, all these which call for very rapid timely action for antimicrobials. So these are something, again, which nursing has a very important role to play for communication. And of course comes the next step then, that is ensuring the adherence to various guidelines. Could be, the prophylactic guidelines. Let's say just for surgical antimicrobial prophylaxis, the agent, timing, when is it being given? Is a redosing done? Does it really require a redosing? And administrating the antibiotic at the correct time as prescribed. And yes, very important, because she is there at the patient bedside the entire time. She would be the first recognize any allergic reactions for the antibiotic, be it some kind of rash or be it some kind of diarrhea. And she would be the first one to call up the treating team and tell them that, yes, there seems to be an allergic reaction, or maybe there's some hypersensitivity, and we need to take a look at it. So that is actually where the role of nursing comes in. And then not just this, when we talk about de-escalation, we look at de-escalation as something which only the primary treating team is to do with. No, it is actually all of the nursing team which actually initiates it. The antibiotic timeout, which we call the review of the antibiotic after 48 to 72 hours, or just initiating the discussion with the treating team of converting from, let's say, an IV to an oral, again a form of de-escalation. Or just the timely communication of the biomarkers, like procalcitonin is so and so. So all this actually helps in de-escalation and appropriate antibiotics. And yes, the very basic concept of identification, something like a multi-drug resistant organism. Like out here, Dr. Sadana has started this very streamlined chain of communication for any MDRO which is recognized in the microbiology lab. So the infection control nurse, it is conveyed immediately to the infection control nurse. The infection control nurse will, in the form of a mailer, will communicate to the area where the patient is, and the contact precautions will be started there and then. So it is that identification, and then it is the role of the ICM. They would go there, they would confirm that proper precautions are being carried out. And not just that, if the patient is shifted to another bedside, to another area, they would also maintain that the precautions are being carried out also out there. So that is just to say some very basic things. Of course, the sterilization and disinfection practices have, they have a very major role to play, and they were covered so well, the decontamination part, etc. So I will not really go on to that again. But again, a very major responsibility and role comes in, I think, just giving small reminders, which we have actually seen have really improved some practices. For example, an area with a low or with a seemingly low compliance to hand hygiene. We always know there are those doctors, those physicians. They are always on the lesser compliance for hand hygiene. We all know that. That is there in every institute, and nursing being the most major hand hygiene compliance. So, if they can just give some reminders when the treating team comes in, uh, if you could just be there with a hand rub and, just offer it to the consultant there. And I'm sure he will not mind, he will actually use it. And you would actually see a kind of increase in the hand hygiene compliance. So that is where we have seen a tremendous role coming into play. Again, the indwelling lines, catheters that are there on the patients, especially the urinary catheters, sometimes they are there, and if I can use that word, they may just forget it is there. It is the nursing who actually brings it to their notice, just reminding them, yes, it is day, let's say day 8 or day 9 for this urinary catheter, or maybe day 10 for such and such antibiotic, and should we consider a change? And is the urinary catheter really required in the first place? So, these are some instances where we have actually seen a very big change in all our setup. And of course, when we talk about a community nurse, the patient family education is primary. So anything to do with antibiotic usage or misuse usage, or even abuse, or something like immunization against some vaccine preventable illnesses. So these could be very well taken care of by the community nurses. And yes, another important aspect which could be covered by them is when we look at something like, let's say, surgical site infection, or maybe something like a PIC line, or a patient undergoing dialysis. So actually, these are the patient population which actually require an oversight of something like a community nurse, who would actually be training them even while at home, and giving them the right care, the right kind of education about it. And about SSI, the right kind of dressing, we all would have seen in some case or the other, a patient who has gone after an uneventful stay post surgery, and maybe he is in some remote area, unfortunately, And because the dressings, the post-operative dressings cannot sometimes be carried out in a hygienic manner, the patient lands up with an SSI. So this can be prevented so well, you know, the SSI, and in fact, the SSI surveillance can also be picked up so well in this manner. So another very major part where the nursing can play a very major role for antimicrobial stewardship is actually prescription audits. So to work in a team, you know, I think the nursing is definitely a very important part of the antimicrobial stewardship team, and they would have a very major role to play in any of the prescription audits. So auditing which antibiotics were given where. So therein comes in the role of surveillance. So of course, the compliance with bundles, as our first speaker highlighted very well, the compliance with bundles is definitely there. And also with that can be, you know, also added on as the compliance with, let's say, surgical prophylaxis or the consumption of antimicrobials, measuring the antimicrobials through the DDD, that's the daily defined dose, or how many actually de-escalated, what is the percentage who could de-escalate, or surveillance through the antimicrobial resistance, that is the antibiogram. So that would be actually where the role would really play a very important part for nursing. And yes, as it was highlighted very well, that it may some may have that concept that it is kind of adding on to the duties of nurses. So I think it should be all our responsibility to have it in mind that it is not simply enough to add to the duties of nurses. No, it is vital that the nursing staff should feel part of the agenda. You know, they should feel part of the whole antimicrobial stewardship program. They should feel part of the infection control program. Their contributions are to be valued and they have to be recognized within the multidisciplinary teams. So I think with that, and because time is running out, I before I hand it back to the chairs, I think there is one question which I can see in the question panel, which talks about. It's come from Miss Shiny Royal Moyon, which says, for CLABSI diagnosis, is it necessary to collect blood culture sample from central line and peripheral line, or to sample from peripheral is accepted? Okay, so I think I'll just explain a little, or would I? Is Sandhya there? Because I think she had talked about surveillance. If not, then I can just take on this. Okay, I don't think I can see her there. So, okay, so see, it is a good practice. One needs to carry on paired blood culture samples. And that is very important, especially because you want to see is the culprit the central line. So you look at the time to detection. If it is something like less than 2 hours, then one does not consider it significant. Then you could weigh the pros and cons. Again, having said that, it is a good practice and one should go in for paired blood samples. Now, sometimes if you just look at it at a very, let's say, at a very bookish manner, there is a kind of thin line between the definition of CLABSI, that is central line associated bloodstream infection, and a CRBSI, that is catheter related bloodstream infection. So for any criteria for defining CRBSI, it is essential that one goes in for a paired blood sampling. Again, there is a proper manner it is carried out. For a CLABSI, if you go by the book definition, you will not find it as a definition criteria for defining CLABSI, But having said that, both the terms are actually interchangeable, CLABSI and CRBSI, that's catheter-related bloodstream infection. So in your routine practices, these terms are interchangeable, and it is always a good practice to be carrying on paired blood culture sampling. So with that, I would hand it back to my chairs for their expert comments, please.
Dr. Ujjwala? Dr. Ujjwala, you like to say something?
Sir, at the end, I think this was our last presentation. At the end, I would like to thank Lina again for a very practical and simple but very nice presentation. And I would also take this opportunity to thank all the speakers and especially all the nursing superintendent, nursing staff, those who have presented very good data and gave so much good presentation. I am really happy to see that they are taking active part in presentation and they really present very well and showed us that how good or how important nursing is. Very, we all know, but they have, again with the example, they have shown that nursing is a very important part of infection control practices. And this is a group like whole teamwork, but they are a crucial and very important aspect, and they have done it wonderfully. I would really take this opportunity to thank Sandhya, Navish, Lina, and all the speakers. Thank you very much. Sir. Sir,
Okay.
please.
And actually, Lina, she has presented very well, summarized all the talk from the different speakers. And like you told that, actually, I'm very impressed by the amount of work or amount of knowledge they have given to us. Thank you so much.
Muted. Jishan, you are not audible.
Not audible, sir.
No, you're
Audible.
Again, go on.
Can't hear.
Hello. Hello.
Yeah.
Am I audible?
No, yes, now.
Sir, thanks for a wonderful and stimulating lecture by our speakers. And also, I would like to thank our chairs for a valuable time. And it was really great and so well organized. Thank you, sir and ma'am. Thank you.
Thank you very much. Thank you all. Bye.
Thank you, ma'am, for giving a platform.
Okay. Thank you, ma'am. Thanks a lot.
Thank you.
Thank you, sir.
Jishan. Thanks, everyone. Thank you, sir.
Thank you, ma'am. Thank you. Thank you, sir.
Thanks, Lina. Thanks.
Thank you, all of you. Thank you. Thank you, ma'am.
निकाल क्यों दिया? ये निकाल क्यों दिया था? ईयरफोन निकाल क्यों दिया? आप ये माइक इसका हाथ में यहाँ पकड़ के बोल